My job this morning is to thank you for coming and also to thank everyone who is joining us now on Zoom and Facebook. We have about 200 people that are joining us from across the country and also internationally. So that tells you a lot about the high esteem with which the Dana-Farber Institute is held. Just so excited for today's presentations. I want to thank Dr. Bookbinder, our panelists, and Dana-Farber for co-hosting this event with us. We know that you are going to have lots and lots of questions, both here in the room and virtually. And so we're going to explain to you how that's going to work. When you were given your packet this morning, we told you that you have paper inside there, and I hope you have a pen. If you do not, or if you run out of paper, if you have so many questions, then just raise your hand. We have three wonderful volunteers over here, Alex and Olivia and Eric. They'll raise their hands now. They're from Vika. There they are. And you can they will pick up your questions from you. If you're here, we'll have two periods of questions and answers, one in the middle and one at the end. Because we want online viewers to be able to hear the questions, they have microphones. And so if you will please raise your hand, they will gather your questions from you, and then they will offer them to our presenters, and the presenters will answer them here from the dais. If you are joining us live and have questions, all I need you to do, please, is either if you are on Facebook or YouTube, put your question into the comments and I'll get that written down. And again, we'll get those to the presenters. If you're joining us through Zoom, please put it in the Q&A tab located at the bottom of your screen. And with that, I'm going to pass the baton to Dr.
So thank you all so much for coming today. It's so incredible to look out and see so many familiar faces. And I think the biggest amazing thing about today is that the world of melanoma has changed so much over the last 10 years. And much of what you're going to hear about, really, we didn't even have the option to talk about 10 years ago and before. And so all of us are so excited to share with you kind of some of the amazing advances that have happened over the last 10, 15 years that have really changed the way we are treating melanoma and impacted many in this audience and beyond in terms of what's going on with melanoma treatment. So I'm super excited to have you all here today. I do need to do a couple administrative things. So one is reading off a little safety announcement. So before this program begins, we'd like to remind you that in the event of an emergency, the stairwells off this floor are located outside the doorway on your right. So if you go out this door to the right and another kind of in the far opposite side of the building, kind of flanking both sides of the building. And then that's a way to get out if there is an emergency. Otherwise, I'm excited to be able to invite up our first speaker. So as mentioned before, keep your questions for after all three speakers, because we're trying to kind of gather the questions together and do a bit of a Q&A at the end of those. So I am thrilled to invite up Megan Meridian. So luckily we have an amazing group of medical oncologists treating melanoma throughout the city. And so we have several of our Mass General Hospital colleagues here today, as well as folks from Dana-Farber. So Megan is from Mass General Hospital. She specializes in treating melanoma, particular interest in the adjuvant and neoadjuvant setting. Also does a lot of work in therapies for patients whose disease has progressed after immunotherapy and novel therapies, and also treating immune side effects from those therapies. So with that, I'm going to invite up Megan. Thank you.
All right, good morning, everyone. And I echo Dr. Bookbinder's comments. So excited to be here with you guys today. And I have the pleasure of being able to talk about this really interesting and evolving space, which is how can we best treat early stage melanoma? And our objectives are really focused on that. And I think most of the talk will be focused on cutaneous melanoma that arises in the skin, and some of the advancements that we've seen in the treatment of resectable disease. Specifically, this kind of adjuvant therapy, that therapy after surgery, neoadjuvant therapy, systemic medication given before surgery, and then this perioperative approach, which is somewhat like a sandwich approach, medications given before and after surgery, all with the goal of reducing the risk of the melanoma coming back. As Dr. Bookbinder was saying, we've really seen an evolution in how we treat melanoma really just over the past 10 years. And it's pretty impressive to think about where we've come and now where we're going. And this is just a slide showing approvals for immunotherapy alone. So many of the talks you'll hear about today, some of these are more burgeoning areas that we don't have approvals quite yet, but where we see approvals is pretty plentiful, really, if you think about advancements just over the last 5 to 10 years. First, in the unresectable space with ipilimumab, a CTLA-4 inhibitor back in 2011, followed by the PD-1 inhibitors, pembrolizumab and nivolumab, and since that time, some combination approaches. And with the improvements that we've seen in the treatment of metastatic melanoma with these drugs, they've shifted to earlier stage disease. Again, all with the goal of saying, can we use some of our best medications first to improve the likelihood of cure? First with high-dose ipilimumab in 2015, followed thereafter by approvals for drugs like pembrolizumab and nivolumab for stage 2 BC melanoma, stage 3 melanoma, and resected stage 4 melanoma. So who are we really talking about when we're thinking about using these medications before and after surgery? And to help understand that, I'm just going to briefly go through the staging system. So melanoma is staged like other solid tumors, stage 1 to stage 4. A stage 1 melanoma is a melanoma that's thin, relegated to kind of the skin and the soft tissue around it. Stage 2 melanoma is a melanoma that is a bit thicker. It may or may not have what's called ulceration, meaning is that top layer disrupted, or is it nice and smooth when the pathologists look at it under the microscope? A stage 3 melanoma is often a melanoma of any thickness, but has evidence of spread to nearby lymph nodes. And that can either be microscopic spread, meaning that when our surgeon like Dr. Cohen takes the patient for a sentinel lymph node biopsy, the pathologist sees microscopic cells in that sample, or what's called macroscopic spread, meaning evidence of melanoma spread that we can either see on a scan or feel on exam. And then stage 4 is that we see melanoma start in the skin with evidence of distant spread elsewhere. And this pie chart breaks down what we consider the incidence of melanoma. So for the patients that we're really focused on, these stage 2, stage 3 intermediate, that makes up about a quarter of the patients that we know are diagnosed each year. So again, when we're thinking about adjuvant therapy after surgery, it's primarily focused on patients who have those thicker stage 2 melanomas or stage 3 melanomas, which encompass spread to those nearby lymph nodes, but again, in a microscopic fashion. So when we think about a patient's journey who may be counseled on these approaches, again, we know that first and foremost, surgery is the treatment of choice. And we're able to get good information about the melanoma through that wide local excision or the sentinel lymph node biopsy. And we know that for the majority of patients, they are cured by this therapy alone. But despite excellent surgery, we understand there is a risk of recurrence. And that's really where these medications come in. Can we use drugs after surgery to reduce that recurrence risk and hopefully improve the likelihood of cure? And the rationale for that is just the concern that even again, after a thorough surgery, potentially a lymph node evaluation, there could be microscopic cells that are left behind. And that's where the use of these drugs really comes into play. And this schematic here showcases the rationale for adjuvant immunotherapy. So you can see the surgeon removes the primary tumor, but in the event that there are microscopic cells left behind, we give these medicines to boost the immune system, to recognize those microscopic cells, hopefully rid them from the body, and improve the likelihood of cure. And we have approvals for a couple different treatments that target what's called BRAF, which we'll explain, and again, these immunotherapy agents. So BRAF, so what exactly is it? And that way we can understand why these drugs may be helpful. So 50% of melanomas that arise in the skin possess what's called an activating BRAF mutation. So you can see what looks like normal cell signaling on the left, and then abnormal cell signaling on the right. And normally when a cell is growing and dividing, it gets a signal from above, it does the job it's supposed to do, and once that job is complete, that signal turns off. But when BRAF is mutated, and this is a sporadic event, it's not hereditary, we don't quite understand why it happens, but we know when it happens, it's implicit in that cell growing and dividing improperly. And when cells are growing and dividing improperly and never get that switch to turn off, that can lead to the development of a tumor. And very smart scientists realized, well, if this is the reason that these cells are growing and dividing badly in the first place, let's try to shut that light switch off. And that's what these medications are attempting to do. So medications like dabrafenib, which target BRAF, and then trametinib, which target that protein right below it, MEK, have shown improvement when we've used them in the treatment of BRAF mutated melanoma. We've seen improvements in the stage 4 setting when we've used these drugs. And then in 2018, we saw improvement in the stage 3 setting. So this was what's called a study scheme or design that looked at how did these drugs do in comparison to placebo, meaning surveillance, which we did for the majority of patients back in 2018 after discussion. So it looked at patients with stage 3 melanoma with one of these activating BRAF mutations, and patients were randomized 1-to-1, meaning 50% got the medications, 50% were monitored, and treatment was continued for a year. And they're really trying to understand how did these drugs do in reducing that risk of recurrence. And we've now had the benefit of time to see that, yes, even when those results were first published and presented, we saw benefit. And now 5 years later, we see the 5-year, what's called recurrence-free survival, how long patients are living without any evidence of that melanoma coming back, favoring the dabrafenib trametinib with 52% versus 36%. So this is an approved therapy that we have and we discuss with our patients. In addition, we know that we have the ability to use medications that target the immune system, like I referenced. So these drugs work completely differently. They're really trying to work to activate our body's own, in a sense, army to stimulate itself, go out and see those cancer cells for what they are and kill them. So the T cell is somewhat like the soldier of the immune system. When that T cell is activated, it can go after things in the body that don't belong, like bacteria, viruses, and in this case, cancer cells. And we know that there are receptors on that T cell surface that can activate it, and then there are receptors on that T cell surface that can inhibit it. And a lot of what we're focused on, both now with medications that we use and medications that are under development, is how do we help activate that T cell, and then how do we help block signals that may inhibit the T cell. And one of those is the PD-1 blockade, those drugs like pembrolizumab and nivolumab. So we know that a cancer cell can actually express this PD-L1 on its surface, and when it binds to the T cell, it can effectively shut it down. So if we block that, our goal is to activate the T cell, see the cancer cell for what it is, and then ideally eliminate it. And I'll only show a couple slides on some of the trials that we've seen in this space, but across the board, we've seen benefit in stage 3 and resectable stage 2. And Checkmate 283 looked at the role of, well, how does nivolumab, that PD-1 inhibitor, work against ipilimumab in patients with stage 3 or resectable stage 4 melanoma. And then Keynote 054 looked at a similar patient population, though stage 3 alone, and looked at the drug pembrolizumab, and this was versus placebo. And the long and short of these figures is very similar to the targeted agents. These drugs did show improvement in that recurrence free survival with reduction in risk when we're thinking about treatment of, again, earlier stage disease. So I think a major question is, why don't we just give these drugs to everyone? We've seen that they reduce the risk of recurrence, but I think the challenge is we really have to be thoughtful about that risk benefit. Like I mentioned, some patients are cured with our exceptional surgeries alone that are performed by our surgical colleagues. And unfortunately, we realize too that these drugs are not perfect. They don't reduce the risk down to 0. So some patients may receive these drugs, but still have a melanoma recurrence. And right now in the clinic, we're not armed with the ability to identify which person falls in each bucket. And we're always very mindful, again, though we would love to decrease the risk as much as we can, these drugs do come with some limitations. One, it's a year of therapy. That's time, that's potential financial toxicity, and there are real risks of side effects. And though I won't have time to really delve too deep, I think one thing I'll mention is these immunotherapy drugs, again, work very differently. They're working to boost our body's own immune system. So in about 10 to 15%, the immune system, in a sense, can lose its way, become dysregulated, and cause inflammation in normal parts of the body. And when that occurs, simply stopping the drug is not a fix. We often have to use medications to help suppress the immune system. And in rare cases, these can be chronic side effects. So again, we really put those into our calculus when we're helping to counsel patients and their families about the best choice. But with that being said, we are now lucky to know that we have several approvals in this adjuvant space after surgery. And this figure and tables just really breaks down kind of what approvals we have in each stage, understanding that yes, we can think about immunotherapy for stage 2B, C, 3, and even resectable stage 4, and then those BRAF targeted therapies in resected stage 3. And I think one area that's garnered a lot of buzz, rightfully so, is this personalized cancer vaccine that many in the audience, I imagine, may have heard about, as it was not only publicized in the academic press, but we saw a lot of interest kind of across the lay press as well. And this is basically a schematic to help understand kind of what is this personalized cancer vaccine, because what we're trying to do is really trying to hone our therapies the best we can to the person in front of us. And this technology is really attempting to do just that. It's taking a patient's individual tumor and looking at the DNA of that tumor itself and trying to understand what mutations are present that may be kind of, again, the lock and key of why this cell is growing and dividing improperly in the first place. And again, very smart, sophisticated science has allowed us to actually target those unique mutations in the tumor itself, a term sometimes called neoantigens, and then formulate a vaccine. And a study looked at this approach in combination with pembrolizumab. So that drug I had referenced is already an approved regimen after surgery. And it looked at patients with a higher risk melanoma stage 3B, C, and D. And 50% of the group got the vaccine plus pembrolizumab, and 50% of the group got the pembrolizumab alone. And we did see improvement in what's called that reduction in recurrence risk. So this is an area that I think we're all very excited about. Can we personalize treatment? Can we see improvement? And notably, this was without significant increase in toxicity. So next steps are a larger study looking at this approach, as well as expanding this to other tumor types. So now what about neoadjuvant therapy? So this is that treatment where we use these drugs before surgery. So why would we do that? We've shown that these drugs can work after, but I think biologically, we're all excited that if we use these drugs before, we might actually stimulate the immune system more effectively. And you can imagine if we're giving a drug through an IV to stimulate the immune system, if that tumor is still in place, it gives the immune system something to recognize. So activation has the potential to be improved. And through what's called kind of preclinical or studies that are done in the lab, we've seen that when we give these medications before, the immune system gets activated more effectively, more T cells and what are called more diverse T cells. So not only can we potentially see shrinkage of the tumor, but we can see, hopefully, and some of the data that I'll show, eradication of those micro metastatic cells more effectively than when we use the adjuvant therapy alone. And this slide, again, just highlights the potential benefit, more effective activation, potentially tumor shrinkage. It gives us an earlier kind of readout of the objective response. And from a research standpoint, really tries to help us understand mechanisms upon which medications might work really well, making a tumor sensitive, or if it doesn't work so well, resistant. So when we think about the patient's journey who might be eligible or who we might consider a neoadjuvant therapy, it's really a melanoma where we have what's called those macroscopic lymph node involvement, lymph nodes that we might be able to see or feel on exam. And medications are given before, patients are taken to surgery with the potential to have additional medications after, of course, with close surveillance. And how do we determine if these work? Well, first and foremost, we still use our tried and true scans. Here we can see CT scans. I've circled what's called an axillary lymph node, a lymph node under the armpit for someone who received medications before or before surgery. So when they were first diagnosed, kind of a bulkier lymph node, and then after 3 cycles of therapy, a much smaller lymph node. And then we also have to lean heavily on our pathology colleagues. So when a lymph node or a group of lymph nodes are removed, they look at these under the microscope for us and tell us, well, what do they see? And they're able to break it down by how many cells they see that are related to cancer under the microscope versus treatment effect, things that look like more necrosis or inflammation. And they can break it down by either they see no cancer cells, a complete response, a near complete response, which is less than 10% cancer cells, and then less than 50%, which is a partial response. And then in the case of limited response, we see more than 50%. And we use these, as I'll talk about, to really try to personalize an approach. In the next few slides, I don't want you to worry too much about these designs or schemas, but more just trying to help you understand. People are working really hard to understand how much therapy do people need. Can we tailor things according to the person in front of us? And this study, which is called Opus-Neo, was a dose finding study. Could we find a sweet spot when we're using the combination of immunotherapy drugs, ipilimumab and nivolumab, just before surgery? So this was the plan, just to give the medications preoperatively with no prescriptive therapy after surgery. And what they found is there seemed to be a sweet spot with respect to the dosing of the ipilimumab at kind of a lower dose of 1 milligram, the nivolumab at a standard dose with respect to the effectiveness, but also trying to minimize the toxicity that someone may experience. And I think the long and short is that people did well when we gave this approach kind of across the board, but we saw that when there was that pathologic response, meaning the pathologist looked at it under the microscope and they really didn't see many tumor cells, we saw kind of slam dunk responses with 96 or higher % of patients not experiencing a recurrence. But if we did see more than 50%, we realized, well, maybe those patients would benefit from more. And that's what this study was really trying to also tease out. Can we personalize each patient's journey? So looking at a similar patient population with the idea of something that could be macroscopically seen or felt, got the dose of ipi/nivo that they had found to be effective, but then they really tailored it based on how did the surgical sample look under the microscope. And instead of every patient getting what's called a total lymph node dissection, where all the lymph nodes are removed, they removed just the dominant lymph node and looked at that response under the microscope and said, okay, if someone's tumor responded well, perhaps we can omit more surgery, we can omit more therapy after. But if we saw a tumor didn't respond as well, well, then we know that escalation might be better, a bigger surgery or perhaps medications after. And again, the key points from this was, again, very encouraging results when we used this therapy before, when we looked across patients, but the best response we're seeing in patients who had that pathologic response. And we knew that when we looked at, well, for the people who fell into that non-responder category, it did seem that more could be beneficial in respect to more surgery and more therapy after. Treatment was overall well tolerated, and like Dr. Cohen will talk about, being able to omit that total lymph node dissection certainly improved surgical outcomes for patients with respect to adverse events and quality of life. And kind of lastly, this is one of the newest studies. It's kind of shaping the way too that we're treating patients in clinic that helped us really tease out, well, what's potentially better? Is neoadjuvant really better than adjuvant? And in this study, they were trying to help us understand it. So looked at more advanced stage 3 and resectable stage 4 cases of melanoma, and patients were randomized either to surgery up front followed by that adjuvant therapy, or the sandwich approach of therapy with pembrolizumab, that PD-1 inhibitor, surgery, and then the potential to complete 1 year of therapy afterwards. And they were looking again to see how did patients do. And we saw that the group that got the neoadjuvant therapy before did seem to fare better in respect to what's called event-free survival, in terms of being able to have the surgery was still very feasible, and that risk reduction. So where do I see things going? I think we know we have great data so far, but we want to build on it. We want to look for new neoadjuvant regimens, which many are underway in clinical trials. This is just a schema that looks at that nivo-rela combination. And then I think importantly, personalizing treatment, both with those respect to escalating or de-escalating therapy, like I talked about, and try to find biomarkers to help us better counsel patients about the risks and benefits of moving forward. And I'll end with just a clinical case, just to showcase that we're using this in the clinic, we're seeing effect. This was the same CT scans that I had shown before. This was a gentleman who had a stage 2 melanoma, initially said, you know what, immunotherapy is not for me because of some other medical issues. Ended up having a recurrence in a palpable right inguinal or right axillary node, which you can see here. We gave 3 cycles of the pembrolizumab. We saw shrinkage on exam, shrinkage on scan, And we saw from our pathology colleagues that this was consistent with a complete pathologic response. This is a patient I share with Dr. Cohen. I also share this patient with Dr. Cohen. This was a melanoma of unknown primary that developed a palpable inguinal lymph node in the groin. This patient was treated on a clinical study, had 3 cycles of therapy. We saw some shrinkage on exam, some shrinkage on imaging, which I've highlighted here. And again, a complete pathologic response. So a lot to be encouraged by. And I think in conclusion, we know that these medications can improve outcomes. We want to be incredibly thoughtful about the way we talk to patients and their families about the pros and cons, particularly in the adjuvant setting. And I think we have a lot to be excited about with respect to future therapies to come. And I thank you guys all for your time.
Trying to get rid of the bar here. All right, excellent. So thank you so much, Dr. Reddy. That was an amazing kind of overview of what's happening in early stage melanoma. But no, therapy of melanoma is not just immunotherapy, not just targeted therapy. Our surgical colleagues are huge collaborators. And I think, every patient has met at some point with a surgeon and knows how important surgery is in the world of melanoma. So we're going to transition now and talk a little about surgery for melanoma. And I have the honor of introducing Dr. Sonia Cohen, who is from the Mass General Hospital as well, and works there in both the melanoma and sarcoma departments. Did her training at Johns Hopkins, MIT, surgical training at MGH, as well as at Memorial Sloan Kettering. And also, in addition to doing surgery for melanoma and sarcoma, also has research interests in the genetics behind many of these cancers and developing new therapies for them. And so with that, I will hand it over to Dr. Cohen.
Thank you. Hi, good morning. I'm really happy to be here. Excited to share kind of how we think about surgery with you, and thankful for being invited. I don't have any disclosures. I wanted to start with why it's such an exciting time to be a surgeon taking care of patients with melanoma. I think historically, surgery was one of the only options we had for patients with all kinds of cancers, and often surgery wasn't successful. And that's really because of the biology of the tumors we were taking care of. But now, this is a time where I get to take care of patients and use surgery as just one of the tools to really help improve outcomes, with the goal of getting our patients through all their treatment, minimizing the risks and getting the best outcomes we possibly can. So that people have a long life with good quality of life. And that's really our goal. So let me see if do you want me to leave this far or? Okay, all right, no problem. So the way I think about these are I just want to outline a few things about how we think about using surgery for melanoma. So one of the questions is why we use surgery to treat melanoma. And really there are 3 things that we think about. One is local control. So whether that's the primary tumor on the skin or, other parts of the body where it arises, or whether that's a metastatic tumor, we want to use surgery to help control that tumor where it is. To prevent it from coming back. And if someone's having symptoms, we can use surgery to help with that. A big part of what I do actually is contribute to the staging of our patients. So right now, with all the data that Dr. Meridian talked about, the most important thing I think I'm contributing to our patients is figuring out, like you saw, 90% of patients come in with a tumor that, is most likely not going to come back. But we're really trying to find those 10% of patients where, we can use other tools to intervene and help improve outcomes. And I'll talk a lot more about that. And then thinking about pathologic response when we're using surgery in combination with these neoadjuvant and adjuvant therapies that you just heard about, that's really somewhere where I can contribute by removing the tumor at some point during the treatment to help us understand how we should support our entire overview of the patient's treatment plan. So then I have to think about which surgery when, and most of my slides will be reviewing that, but thinking about wide local excisions, the sentinel lymph node biopsy versus removing all the lymph nodes, the index node that we use along with our adjuvant therapies, metastectomy, which is when a patient might have disease that's pretty well under control, even though they might have metastases, and maybe there are 1 or 2 tumors that I can help by removing to make it so that they have less burden of disease. And finally, something I won't really talk about, but I did want to mention, we do have other options for patients that aren't responding to our standard treatments, such as perfusing a limb with chemotherapy to try and help with the response to treatment. And there is some active research going on combining this kind of old technique with new treatments we have, such as immunotherapy, to see if we can improve outcomes. All right, and then finally, how do we, a lot of what I'm going to show you today is the data that guides how I actually do the surgery. So like what margins do I use, and how do I approach a local problem versus a systemic problem? So I want to start with the history of the surgical management of melanoma. And with many cancers, historically, like in the 1800s, once we had anesthesia and surgery actually became a tool that we could use and get patients to survive, with advances in treating infection and things like that. Surgery was very aggressive for diseases like melanoma because it was really the best tool that we had. So in 1820, there's some papers from a physician called Norris who described tumors rising from pigmented lesions in 2 families. And that was kind of the first description in the literature of probably was melanoma. But what they noticed is that even after they would resect these tumors, there were really high rates of local recurrence, meaning either in the skin where the tumor was removed from or in the draining lymph node basins. And this observation sort of helped shape how we learned about melanoma going forward. So then in the 1900s, really the best tool we had was surgical management. And, we were doing huge surgeries, not me, I wasn't there then, but, the field was doing huge surgeries for these tumors with 5-centimeter margins, which is a very significant amount of tissue, removing all the lymph nodes because of this observation that it tended to recur locally in the lymph node basins. And these were really morbid procedures, and patients didn't do that well. And so I'm really excited that, we're here, this era that we're treating patients in. It's really a modern era where all our data is based on surgical trials, multidisciplinary care, and we get much better outcomes. So this is a different way of looking at the staging that Dr. Meridian showed you in the last scan. And this is really what I am using all the time to try and think about my patients. Are they coming in with a precursor to melanoma? Are they coming in with stage 1 or 2 disease? That's really 90% of our patients. Or are they coming in with more advanced disease, stage 3 or stage 4, where then I'm going to try and use the surgery and possibly nodal evaluation to really help figure out exactly where our patients are on this chart. This staging, this is the AJCC 8th edition. It came from over 50,000 patients that we've been collecting data from as a field since 1998. And it's based on really histopathological data. So what Dr. Meridian showed you that the pathologists are looking at under the microscope, how thick the tumor is it ulcerated? And this is sort of what helps us to really understand, based on what we know about a patient from looking at their tumor under the microscope, both in the skin and in the nodes, how do we kind of predict who is going to do well and who could use additional treatment to help them do well? And this is because, as I think it will be a theme here, the tumor biology is really reflected in these factors. And that's really why we're using staging. We're trying to figure out, is this a tumor that has good biology, the patient's going to do well? Is this a tumor with more challenging biology and we need to throw more tools at it? Okay, so we kind of reviewed this with Dr. Meridian, just thinking about what I wanted to show you were the layers of the skin, because I think that helps to understand why we do surgery the way we do. So the melanocytes, which are the cells that melanoma come from, are really in this bottom of the epidermis, which is the top thinnest layer of the skin. And then you have quite a thick dermis underlying that, shown here. And what you see is that as melanoma progresses, the depth that is measured by the pathologist, shown here, is really what is driving how we think about the stage of the tumor. And this is because when we look at that staging system that we have and think about patients across the stages, a thin tumor really is a lower risk tumor, meaning here that the chance of this recurring is low. But then as you move up to thicker and thicker tumors, that risk goes up. So most of the patients who come in come with stage 1 or 2 disease, and the central part of their treatment is going to be surgery with a wide local excision. We know from a lot of studies that the local recurrence for these thin, low-risk melanomas after a wide local excision is pretty low. It's less than 6%. So often surgery is curative. And so again, the goal of that excision is to give us good disease control at the primary site. And what we are thinking about when we're evaluating patients and making our recommendations is how do we balance that disease control with the surgical morbidity. So thinking about things like wound healing, whether we're going to need a skin graft to close the wound based on where it is on the body, and thinking about impaired function, such as, tumor that arises in a nail. If we have to do an amputation to really get good margins on that tumor, how is that going to affect the patient's function? Do we have other tools we could use to try and prevent impairing that function? And then also poor cosmetic outcomes, because it is important, especially for melanomas on the face or other places, to make sure patients have good quality of life after their surgery. So these are some examples to show you how that comes into play. Here I'm showing you actually what was a melanoma in situ, so a precursor to melanoma, but a pretty big lesion on a patient's arm. And what's outlined here is in the dark solid line is a 0.5 centimeter margin. So what you can see is removing that tumor on the patient's arm is going to make it very hard to close that defect that we create. So we have to think about other ways to close it with a skin graft or other methods. And then showing you here on the right is an example of a patient with melanoma on the back. There we have a lot more tissue to work with. So here, in the dotted line, we've outlined where the tumor is. The blue dye is a dye we use for sentinel lymph node biopsy, which I'll talk about in the next slides. The dark line is the margin we had to take in this case because it was a deeper tumor, so we need a wider margin. I'll go into how we decide that. But what you can see is by changing the shape of the excision we make, we're able to take that pretty big defect and turn it into a straight line scar that's going to heal nicely and look better for the patient. So why do we use the margins we use? And this is all based on big studies and pretty good data that's actually still evolving. So the first 2 studies were basically comparing for thin melanomas. So melanomas are less than 1 millimeter thick on that Breslow depth that the pathologist measures. Comparing, because historically people used 5 centimeter margins, then they were seeing that they could probably get away with less. But they're wondering what's safe. How thin can we go and still achieve good rates of making sure that the tumor doesn't come back locally? So one trial was comparing 2 centimeter margins to 5 centimeter margins, those historical big margins for these thin tumors. And the other study was comparing 1 centimeter versus 3 centimeter margins. And what we learned is that for 1 centimeter margins, the local recurrence rates were equivalent, whether you did 1 centimeter margins or 3 centimeter margins, I'm sorry. And that for those thicker tumors up to 2 millimeters, 2 centimeter margins were safe when you compare them to 5 centimeters. So the conclusion for that trial was that, we probably can use 1 centimeter for the thinnest tumors, and we probably can use 2 centimeters for tumors up to 2 millimeters thick. And that really helped us move away from these huge excisions that we were doing previously to that. So then the next sort of round of evaluations of studies where people looked at patients and the different margins they were taking surgically to see how patients did afterwards, we're looking at the tumors that were more than 2 millimeters thick, so that more in that intermediate heading up to the thick range. And here they were comparing 2 centimeters to 4 centimeters, and they showed that there was no difference in the rate of recurrence or how the patients did long-term. And so that taught us that 2 centimeter margins were safe even for melanomas greater than 2 millimeters thick. And so that sort of led to these recommendations. I took these from the NCCN guidelines, which really guide a lot of what we do. And it shows that depending on the tumor thickness, so whether it's a precursor to melanoma or a Breslow depth going from less than 1 to greater than 4 millimeters, we use this to help us decide which margins are safe in terms of local recurrence to guide the margins we take for surgery. And so, let me see if I can. So I'll just tell you what it says below where you can't see, but you know, kind of where the action is happening right now for this is two centimeter margins is still can be pretty morbid, especially if we're talking about something on the face or someone's hand or foot, where it really changes the amount of surgery and the amount of recovery time it takes. So there's some question, I think a lot of us believe that probably 1 centimeter margin, especially today where we have all these other tools to help us deal with tumors that have bad biology, might be safe. And part of the reason is that the original trials that were comparing the 1 to 3 centimeter margin for these thicker tumors were really all done in an era before we had these new medications. And actually, they didn't even allow for evaluation of sentinel lymph node in those trials. So those patients couldn't have any other treatment either than the wide local excision, which just isn't really up to our modern standards. And what they found, if you look back at those studies, all the recurrences they have weren't locally where we remove the tumor, they're all in the node systemically. And so I think a lot of us believe that probably we can get away with even less at that primary site, help our patients heal up better, and use these other new tools we have to deal with tumors that spread. And so right now, what's going on is this trial, which is called MELMART-2. And that's really comparing whether 1 centimeter margins is safe for these thicker tumors, but in the modern era. So it's allowing all our normal treatment. It's allowing us to look in the lymph nodes, allowing patients to get additional treatment. But because the outcomes we're looking for are probably going to be subtle, it's going to take a lot of patients and a lot of time. So it's probably going to be, I think the projected end date for this trial is not until 2029. So it's going to be a while before we really have the data to back up sort of how we think the field will advance. Okay, so moving on to lymph node surgery, I wanted to talk about why we think about lymph nodes, and Dr. Meridian introduced this in her talk as well. But if you look at that schematic of the skin and where the tumor starts, where the melanocytes are, and then the dermis and the subcutaneous fat underneath, what you can see is that the lymphatics actually extend into the dermis. And so when you think about a melanoma that is growing in the epidermis and getting deeper, and it starts to encounter these lymphatic channels that drain all the interstitial fluid, all the fluid that your tissues make into your lymphovascular system. And what's happening there is that's where your immune system is really filtering all that fluid and looking to surveilling for cancer. And this is just a schematic showing you where all the lymph nodes are in your body. So, you know, you have the local lymphatics in the dermis, and then that's all being drained to different stations where you have concentrations of lymph nodes that are doing this immune surveillance. So historically for nodal surgery, like I said, it's been recognized for a long time that melanoma tends to go to the lymph nodes. That's different than some other cancers that tends to go to the lungs, and that's because it spreads through the blood rather than the lymphatics primarily. And at that time, because of this observation, surgeons were just going in any patient with melanoma, they would just take all the lymph nodes out in a basin. So if you had a melanoma on your arm, they would, you know, preemptively remove all the lymph nodes in your armpit. And what the problem with that is that it's very morbid procedure. You're basically, you know, a 50-50 chance you're going to get infection from that. And up to 30% of patients will have long-term lymphedema, which can be, it's a swelling in the limb that really can be debilitating over time. So people were interested in improving outcomes for patients. And Dr. Balk, you know, probably like in the 90s, early 2000s, demonstrated that really when you looked at the specimens, when people removed all the lymph nodes for a patient with melanoma, let's say from the armpit, and looked and saw how many of the lymph nodes that they were actually removing actually had melanoma in them, it was only 20%. So 80% of the lymph nodes removed, even in a patient who had metastases to lymph nodes, only had 20% of those lymph nodes with disease. And so they were thinking, is it possible that we could remove just the lymph nodes that had tumor in them and leave the other lymph nodes and hopefully improve outcomes for the patient? And that was really the motivation for something called the sentinel lymph node biopsy that was developed by Don Morton and his client and his colleagues. And they were really interested in just removing the lymph nodes that we had to remove. And that led to a lot of basic research looking into how the lymphatic system drained the skin, and could we actually trace the lymph nodes that drain a particular part of the skin to remove the appropriate. And so this is a schematic showing the sentinel lymph node biopsy, which is what they came up for and have shown with a lot of great data across a lot of diseases that this works. So what I'm showing here is if you imagine a melanoma on a patient's abdomen, that skin drains to lymphatics that end up concentrated in lymph nodes either in the groin or in the armpit, can actually cross to the other side. So it becomes really important because it's not necessarily stereotyped to actually mark and trace where those lymph nodes are that drain that skin, so that then you can go and pick out exactly the lymph nodes you want to test to see if there's melanoma there and remove them. And so that's a very nice picture showing ideally how it looked. This is actually the kind of information we get. This is showing a patient where you can see this big blob of injection. It's a radioactive nucleotide that they're injecting into the skin, and then it gets taken up by lymphatics, mimicking the same way a cancer cell would travel if it was going to travel. And it shows which lymph nodes it's concentrated in. But we have a little probe that we use in the operating room, and that helps us really figure out which lymph nodes and which basin we need to remove. And then historically, we used to use that blue dye that I showed you before, but that we don't use that as often anymore. We might use it in tricky cases. Okay, so then we started to move into an era where, okay, we know we can use this tool, the sentinel lymph node biopsy, to identify which lymph nodes drain the skin and might have cancer in them, and remove those preferentially. And initially, the way this was used was that you would do the sentinel lymph node biopsy, and then you would immediately remove all the lymph nodes that were in that basin if the patient showed any evidence of metastatic melanoma in the lymph node. And so initially, when this was being developed, the question was, is it safe? Can we do this? Does it actually help? In this trial, the MSLT1 trial, this was really looking at, you did your wide excision, and then you could either watch the patient or you could do this lymph node surgery, the sentinel lymph node biopsy, and then the complete lymph node dissection. Did this help? And so most patients, we learned, had a negative sentinel lymph node biopsy, and that's because most patients just have disease limited to stage 1 disease limited to the skin. Even in patients who had a positive sentinel lymph node biopsy, again, only 80% of patients had other lymph nodes when you remove the rest of the lymph nodes that had melanoma in them. So for 20% of the patients, it was potentially useful to remove that whole basin, but for 80%, we were probably doing too much surgery, and just removing the sentinel nodes was enough. And importantly, what we learned is that doing the sentinel lymph node biopsy, followed by the complete dissection, didn't necessarily improve survival rates. But it did give us a lot more information about that patient and what their risk was of the melanoma coming back. So that was kind of our first clue, that doing the surgery didn't necessarily change the outcomes for the patients, but it did help us predict how that patient was going to do and help us treat them appropriately. So then the next phase of the trial, MSLT2, came up, and that was really designed to ask that question. So does doing that big lymph node dissection in patients with a positive sentinel lymph node biopsy improve outcomes? And the way this study was done is that you either got your sentinel lymph node biopsy and then we watched you really carefully, or you got your sentinel lymph node biopsy and you went ahead and got that bigger surgery to remove all the lymph nodes. And what we learned from that study is that actually it didn't improve survival. So patients didn't necessarily survive longer by us doing this bigger, morbid surgery. It did reduce the rates of the tumor coming back in the lymph nodes, but that's kind of makes sense because we've removed the lymph nodes. And what we learned was that, it's probably safe to watch patients and wait for that 20% of patients to have more disease come back, and then treat them then, rather than preemptively giving everyone with a positive sentinel lymph node the morbidity of the surgery. And here, again, it's blocked a little, but what I'm showing you is that, this study again showed that if you do a complete lymph node dissection, up to 25% of patients in that study had clinically significant lymphedema that they had to live with for the rest of their lives. And, 80% of the patients who got that didn't necessarily need it. Whereas if we just did the sentinel lymph node biopsy, the rates of lymphedema were much lower. Okay, and then the last point I want to make is all this data is even before we had effective therapies like Dr. Murray talked about. So we were able to already say, probably we should just be doing the sentinel lymph node biopsy and then watching patients. even before we had better ways to treat patients and improve their long-term outcomes. And that brings up the last kind of word I wanted to use, which is salvage. So oftentimes as a surgeon, what we're thinking about is, should I use my surgery now? Even though I know it might, cause some long-term complications for my patient, or should I save it and just use it for those patients that I need to salvage if their disease comes back and then I can use surgery. And I think so we've all sort of moved to this approach where we really use the nodal surgery for the sentinel lymph node biopsy in patients that qualify for it, based on how their primary tumor looks under the microscope. And then we save the bigger surgery for the patients where we don't have other options. Okay, so putting the data together, we recommend wide local excision for all individuals with local regional disease. I'm just here again is the margins we use based on the data I showed you, and we are trying to move towards what we think are safer and smaller margins. Again, it doesn't matter that much if the tumor is on someone's belly. Most of us have extra skin there that, it's not a big deal. But for other areas like the face or the hands or the feet, it can make a big difference in how a patient does and really affect their quality of life if we have to do a bigger surgery. And then the other part of this is what I'm really doing is a lot of surgery to help really give a good stage to my colleagues in medical oncology. So once I've done all my surgery, I've looked at the primary tumor and removed it. I've looked at the lymph nodes. I'm able to say to my colleagues, this is a patient with a tumor that we know from our data probably needs more therapy, and I've passed them on to them. And then finally, we still do use our complete lymphadenectomy or some of our more morbid surgeries in some cases. So patients who had nodal metastases that would come in and that's their first presenting symptom, or during surveillance it comes up, we might offer them a complete node dissection either with or without adjuvant therapy. Patients with the positive sentinel nodes who can't get further surveillance for some reason, they don't live with accessibility to medical care, or for some reason they can't have additional treatment, but they really systemic treatment, but they really need it. Those are also patients we might offer additional surgery to. And then finally, patients where we really do need to palliate some symptoms, if that's the best option for them, and we don't have other less morbid ways to deal with that. We talked about a little bit surgery for melanoma in the context of metastatic disease. So we will remove tumors to help Dr. Meridian look at the response to neoadjuvant treatment, figure out how to change their therapy going forward to try and get the best response. Sometimes patients might have disease that's responding overall to systemic therapy, but maybe one tumor that's not responding, so we can remove that to help get rid of any tumor that might have evolved some way to evade the therapies that are working for the rest of their disease. And finally, as you'll hear later, we do have really exciting new cell-based therapies under development, and often the surgeon will help by harvesting tumor to develop that for our patients. And then finally, I just wanted to say thank you to all our patients who help us learn more about melanoma. A lot of what we do as surgeons is actually collect the tumor, see the tumor in the operating room, think of hypotheses for why we think melanoma might be behaving the way it is, and collaborating with other groups, scientists, really the field at large to try and come up with new methods to treat melanoma. That's it. Thank you.
Oh, excellent. So thank you so much, Dr. Cohen. That was excellent. It's so wonderful you see how closely we all work together, surgical oncologists, medical oncologists, and even our radiation oncologists and other. So now we're going to transition a little from kind of what is standard, although a lot of what we heard from Dr. Meridian, that was really the neoadjuvant approaches, which are rapidly emerging and still we're doing a lot of work in. to a bit more what is coming. And so I'm thrilled now to introduce Dr. Patrick Ott, a close colleague of mine in medical oncology at Dana-Farber here, whose interest is in all sorts of things, including novel therapies for melanoma, but in particular in vaccine therapy and in neoantigen vaccines for melanoma. And so I'm going to hand it over to him to tell you all about that.
Thank you very much. Thanks for the introduction. I'm also really exciting to be here this morning. I hope this actually works being this far away from the microphone, right? You get feedback from like people can actually hear. Okay, sounds good. All right, so I wanted to spend a couple of minutes on this slide here because I really wanted to convey what our objective is when we give vaccines for cancer. And Dr. Morini really gave a great introduction to the T cell already, right? It's also been called that our T cells in our body have also been called the T cell army. But when we do immunotherapy, including actually all the, we call it the checkpoint inhibitors, which is really the PD-1 inhibition, the CTLA-4 inhibition, and the LAG-3 inhibition, mainly, which was also already introduced this morning. But what we really do with these therapies, we want to increase the frequencies of the T cells. So we want to get more of these T cells into the tumor. It's also been called like changing or converting a cold tumor into a hot tumor, right? So we basically want to get as many as possible of these cells in there. And why do we want to do that? What's sort of attractive about T cells? Well, they have memory function, meaning they can actually learn how to do their function over a long time. They can actually learn this and then use it like years later. And that's a little bit, we'll get to the COVID vaccine analogy in a little bit, but basically that's what vaccines are all about, right? So you basically get a vaccine and then you're protected years later. The other feature really with the T cells is like how do they work and how do they function? And so there's two different systems with in our immune response. There's like what we call the innate immune response, and there's called the adaptive immune response. And the T cells are part of the adaptive immune response, which means that they actually recognize specific antigens. And so in the COVID world, right? So we've all lived through 3 years of like what feels forever, but it's also like been a lot of like everybody going through like development of vaccine, right? So you could on many different levels, but you could certainly read in the New York Times about like vaccine development, how the different fact. A lot of talk has been about the spike protein, right? So which is basically the antigen of the virus, right? The same thing applies to cancer in a way that we actually want to steer these T cells against antigens, right? But the antigens in cancer are much more complex. Meaning that we don't actually always really know what the antigens are on these cancer cells, and the cancer vaccine field has been around for decades. And one of the major challenges really has been to know what are the antigens that we should actually vaccinate against. And then just the third point on this slide is like, well, most of the vaccines in the infectious disease world, if you will, which is the majority of vaccines, it's typically prophylactic. I mean, you basically vaccinate and then like sort of the virus hits the body, maybe weeks, months, or years later. Versus in cancer, the target or sort of the cancer cell is typically already around. And that could be like, it could be a patient with metastatic cancer, but it could also be like all the settings that we talked about where there is a melanoma that gets surgically resected and be worried about a recurrence, but what it basically comes down to is this micrometastatic disease. But the bottom line is like the cancer cells are already there when you're vaccinating. And that's like a challenge, as you can imagine. And then maybe the fourth point is like, because there's so many antigens, what we think is like, we probably shouldn't vaccinate against just one antigen, but against several. And that goes at that's like we call it clonal heterogeneity. There's actually tumor and cancer evolution, meaning like the cancer cells change over time, the composition changes. And so how do you like do that? How do you account for that therapeutically? We think is like, well, it's not gonna be enough to just pick one antigen and then hope that that's gonna do the job. And that's actually illustrated here with different colors in the picture. And then just I sort of made the point already, but it illustrates it here. So what is the difference between infectious disease and cancer? Is like on the left side, you see there's this, you actually see this. Oh yeah. So basically when that COVID virus, you get infected with it, the immune system has never seen it. So it's like foreign, and it's by definition immunogenic because it's something that doesn't really belong to the body, right? It's not really something that the immune system has sort of learned not to recognize. Versus for cancer, it's sort of in between. So cancer cells are, not exactly normal body cells, but they have arisen from normal body cells. And they're therefore, our job is to actually figure out what can we actually vaccinate against that's not what the immune system has not already learned that it shouldn't respond against. And then also it's like a long process. It's not something where the virus comes from one day to the next. It's something that those cancer cells we think have sometimes evolved over years, and the cancer actually has learned to evade the immune response. Okay, how do we vaccinate? There's a lot of talk about RNA, right? So everybody knows about like RNA is a great, what we call a vaccine platform. But actually before COVID, that wasn't the case at all. It was actually that our RNA has never been used as a vaccine before. We actually used the reason why we call it platform is basically we have to find a way to deliver that antigen, and you can do that in different ways. So you can use like peptides, you can use proteins, you can actually use DNA, because it can cause viral vectors. And the whole development history of COVID vaccine also illustrated that too. So different companies use those different platforms. There's different ways to deliver those vaccines. So it can actually, some vaccines are injected, as you know, in the muscle. They can be injected in the skin. Some of the vaccines are actually given IV, but you can also like do different intervals. So you can give, again, like the analogy with the COVID. It's like a prime. So you get your first COVID shot, and then like a couple of weeks later, get the next one. Now we talk all about boosters, but there's a lot of empiricism to it. So we don't really know whether that's actually the right strategy. And you can imagine, because of the cancer vaccine are so much more complex, there's even more uncertainty, like what is actually the best dose. And then the third point on this slide here is like, probably we actually have to give the vaccines in combination, for example, with checkpoint inhibitors or other agents that can sort of additionally stimulate the immune response. And then now we're getting to personalization, right? And I just wanted to make a comment. So that the word neoantigen has already been introduced, and that's important because neoantigens are essentially the proteins that are encoded by mutations, right? So all tumors have mutations. Melanoma is actually one of the most highly mutated tumors, if not the most highly mutated tumors. So typically in a melanoma, when we find the mutations by sequencing, we can find hundreds, if not thousands of mutations. But there's also a spectrum. So some melanomas have fewer and some have more mutations. But the reason why neoantigens are important is because because we can actually now identify them with sequencing, which really wasn't possible even like 15 years ago, right? So there was simply not the technology to actually sequence a tumor, find out about the mutation for a patient. It would cost like millions of dollars. It would take like months, if not years. But the ability to actually do that on a sort of timely basis, and actually also in a reasonable price, sort of allowed us to use the neoantigens for vaccines. We know that the neoantigens are actually important for those treatments that are not vaccines, right? The immune checkpoint inhibitors work better in tumors that have more neoantigens. And then the other part is like the personalization, right? So why is this like a personal approach? Well, this is actually illustrated here. Most mutations are what we call private. So there is like, we know about, and they have already been discussed too, like there's this BRAF mutation, right? Half of patients with melanoma have a BRAF mutation. But as I mentioned, there's like hundreds of thousands, of which are actually the ones that we should vaccinate against, right? So it turns out like, well, ideally you would want to vaccinate against BRAF, right? Because you know it, 50% of the patient have it, why not just doing a BRAF vaccine? Well, the reason for that is, number one, it's only half the patient. Number two, not every patient's immune system can actually even recognize their own BRAF mutation when they have it because of this diversity of HLA. So when you think about like transplant and stuff, so you know that that each patient's immune system is different. That's why you have to match donors, and that diversity is reflected in this. So let's say you have like 50% of patients have a BRAF mutation, probably only like 20% of them actually have the right HLA to do a vaccine. So here's where we then get at the personalization. Because we have all these other mutations, we can target hundreds and potentially hundreds of mutations, but they're different in each individual tumor. And so you cannot just pick a couple and then design a vaccine, although that has been tried. But if you want to really make this a treatment that's a therapeutic for all melanoma patients, ideally, you have to personalize. And I just one plug sort of the word personalization. I feel like that's in some sense a little bit overused, and there's like some maybe even confusion, right? So you can tailor treatments depending on what we have. So BRAF is actually the best example. Half of melanoma patients have a BRAF, as I mentioned. So you're not only going to give those target therapies those half of the patient, right? In a way that's personalized. You find out the mutation and then give the drug only to half of the patients. But of course, like the other 50% that don't have the BRAF mutation, they kind of they don't have a therapy, right? Versus like in my sense, like a true personalized therapy is actually where you custom make the vaccine, right? So basically, or you might custom make the therapy. You basically account for the differences in the tumors, and then you design a vaccine for each individual patient. And so that is it's just, I think the advantages are that you don't, it's not stratified. You don't just select patients out based on how their tumor, and then there's sort of the patients who are lucky enough to have that right, like composition of genes or whatever, versus you say like, well, let's make a vaccine, and we know that we can make a vaccine, we just have to like custom design it. But of course, that's challenging because it takes, of course, money, time, and like there's a lot of complexity to do this customized vaccine. As I've already been mentioned, how do we, and I mentioned just in a couple of minutes ago, how do we know what the mutations are? You actually need the tumor, you need a blood sample, you sequence it, and then you call the mutation. So it's actually, when you sequence, you have like all these like different, a ton of information, but you actually have to make sense out of it. And this is not easy. It's becoming easier as we have like more computational analysis. But I will say, even with the tools that we have now, it's actually more complicated than most people realize. And then because of this, the HLA that I also mentioned, you have to like, then not only have to call the mutations, but you also have to really pick which you think are the ones. So out of those hundreds of thousands of mutations in the tumor, you cannot vaccinate against 1,000 mutations. You pick 20 or so, and then you find out like which are the best 20, which are the ones do you think actually the immune system will recognize. And that's basically reflected here, just like pipeline that we use where you need the tissue first, you do all this like analysis, computational analysis, and sequencing, then you end up with like the right mutations to vaccinate against, and then you make your vaccine. Typically, it takes like 3 months, although the timelines are definitely getting quicker. So when we first started this here 10 years ago with melanoma, we used peptide. Our first study was in high-risk melanoma patients, so the same patients that were already essentially had a lymph node metastasis, it was resected, they were free of melanoma, they received the vaccines. I'm not going to go into like too much detail what the vaccines were like, only to say that we actually saw really nice immune responses in all of the patients against many of the antigens that we were vaccinated against. And that was like quite remarkable at the time, because like despite, as I mentioned, decades of vaccine design and development, there really hadn't, this kind of consistency and robustness of responses hadn't been seen before. And we actually, in the study really only had 6 patients, but actually 2 out of those 6 patients had metastatic disease, so they had lung metastases. Their lung metastasis actually came back while we were vaccinated, sort of illustrating the point that I made earlier, that the vaccine alone may actually not be enough, but a certain, or it may take more time for the vaccine to work. And so you need something that's not vaccine to treat for a metastatic patient. But they both then got pembrolizumab, and both of them actually had complete response, meaning like regression of all tumors that's maintained till this day, which is, that can happen with PD-1 inhibition alone. But I would say it's at least unusual to have 2 patients and it happens for both of them. So it's suggesting that because they got the vaccines before the pembrolizumab, they may actually have had sort of this immune response that I was talking about, where you basically get these T cells ready to and have like higher numbers, and then you use the drug that actually then releases those breaks, and that's sort of the ideal combination. We then actually followed these 6 patients longer, and after an average of 3.5 to 4 years, they were all still alive. A few of them actually had recurrences. But the most important thing that we'll show on this slide, so we basically got more blood years later, and then we're able to test the immune responses against the vaccines again after an average of 2.5 to 3 years. And lo and behold, we actually, the majority of the immune responses that we saw after like just a few months were maintained after years, which is really, that's sort of exciting because it really shows you that these memory function of the T cells is something that you can induce with a vaccine. And then we did sort of fancier analysis, but it's also a little bit of a plot, like when we collect tumors and we collect blood, we actually want to learn from this. And there's lots of tools that we have now, some of them called single cell analysis, where we can actually look at single cells, we can look at function of these cells. And with a vaccine, we can actually look at T cells that are specific, that we know are specific for the vaccines, and we can look at their gene panels. And what we showed in that long-term study is actually that those T cells exhibit a memory phenotype. And sort of the function of these T cells was exactly the way you would expect it to be. And then we also looked at, I mentioned like all these different specificities and the different antigens. That is actually taken care of by the T cells because they have what's called a T cell receptor, and they are extremely specific. And what we think that what's happening after vaccination is like there's like this diversification, meaning like that T cell repertoire gets broader and sort of encompasses more specificities. And that's exactly what we saw happening after a couple of years when we looked at, on a single cell level, these T cell receptors of vaccine specific T cells. And so just a plug here, like this was actually novel enough, and it was recognized that vaccines could work for cancer, and it was considered a pioneering study because it was really like the first time that these new antibodies, these new targets were used, and nature sort of recognized as one of the milestones in vaccine, which I thought is kind of nice because when you see it actually down to like the 1700s and sort of have it stamped as like one of those milestones was kind of nice. And so this was really the first study. There was an effort to broaden this concept, and actually the team here at Dana-Farber founded a company called Therapeutics to put this on a larger scale. And so a study was designed where what I mentioned before, basically go into metastatic disease, and you combine with PD-1 inhibition. I'm just going to show a couple of data points from that trial. So there was like a much larger study that had like 60 patients. The majority of them were melanoma. They received nivolumab while the vaccines were made. They were then vaccinated, and then they continued nivolumab. And again, so those were metastatic patients. And so what we see here is like waterfall plots. I don't think we have seen any this morning, but basically that's a way for us to like look at tumor responses. A bar that goes down is good because it means that the tumor regresses. And what we saw in the melanoma cohort, this is individual patients. There were a couple that had like progression, so the tumors became larger, but the majority actually had regression. And then the difference between these like dark and more brighter bars is like after the PD-1 inhibition, there was already response, and some of the patients actually then had deepening of these responses, meaning further regression after the vaccine. And so this is actually this observation of the PD-1 inhibition, which is the standard of care, doing something, is actually reflected here, where we had patients that had tumor biopsies before the PD-1 inhibition, before the vaccine, and after the vaccine. There was actually 5 patients who had like great responses under PD-1 inhibition. So that's like obviously what we want to see when we just do standard of care. You have seen already slides. It's essentially you treat, you look at the tumor, and you see the tumor regressed completely. But there was actually 9 patients who didn't have that. So basically they got normal treatment. They had biopsies, and then the pathologist looked at these biopsies of the tumor, and the tumor had not regressed. But then actually after the vaccine, they had regressed. So basically prior to the vaccine, this year, and then after the vaccine, the tumors had all regressed, and actually patients who had this regression did better than patients who did not. So sort of suggesting that the vaccine had an effect. I'm actually gonna probably skip over this here. It's just like a phenomenon that we call epitope spreading, where we look at whether the immune response actually goes beyond the vaccine. So you vaccinate it, and the immune response actually starts recognizing even antigens that they were not vaccinated against, which could suggest that tumors sort of that the cells actually got killed and exposed more antigens and then primed more immune responses, which we sort of like to see in immunology, because like that could suggest that there's actually a specific response or a specific killing of tumor cells. So you've seen already this data, so I'm not going to belabor it, but why is there so much excitement? Why has it been in the lay press? Like, why is this like a big deal? Well, because it's really the first, this study where 150 patients with melanoma, with stage 3 melanoma, were treated. 100 of them got the standard of care, Keytruda or pembrolizumab, along with an RNA vaccine. Study was done by Moderna, and 50 of the patients only got the standard of care. And so it's called a 2-to-1 randomization. I would say it's like a relatively small study. It's like a phase 2 study that can show us like statistically significant differences, but it's not typically thought to be a study that tells us that it actually works. And so, so it actually works sort of when it works reliably enough that it should be FDA approved. But you saw a difference, and something like this has never been seen with a cancer vaccine before. That's why there's all this excitement about it. How much time do we have?
Not much, you're up.
Okay. All right, so I'm here just gonna show one slide here. So we have like, we actually wanna make these vaccines better. We have like more trials now. We combine them with more things at Dana-Farber, for example, drugs like montanide and ipilimumab that we inject right next to the vaccine. And basically just a plug for like what we do when we do this like tumor biopsies and the leukapheresis is like we do a single cell analysis. And I think we were quite excited to have a patient where we followed the tumors over time while they were vaccinated. We saw tumor regression, but we also saw when we looked at these T cell receptors that there was new T cells that were induced after the vaccine on a single cell level. So that's like it just tells you a little bit like we can do fancy analysis, but they can actually be super informative to help us like actually figuring out like, well, we vaccinate against something, is it actually reactive, and what are the T cell receptors doing? And like, so that really helps us like developing novel or the next iteration or generation of these vaccines. And so there's still quite a few challenges. So we don't really have the best way to really pick the right neoantigens. It's like we have pipelines that we think are pretty good, but there's a lot of room to make them better. We can certainly increase the manufacturing capacities, and we can sort of shrink that time frame. And then ideally, we really want to make these vaccines even stronger than they are, meaning that we want to what's called prime the T cells better than we currently can do. And we probably also have to combine, as I mentioned, with drugs that can counteract what's going on in the tumor itself. And then we can work on like even new antigens. This is just to say that it's like the work, you think like it's like 6 patients in a trial, but there's actually like the team that's developing this, at least in the very beginning, there was like about 30 to 40 people involved. So thank you.
Down, raise your hand.
So now we're gonna transition to the Q&A, and I was actually gonna see if the 3 speakers would be willing to kind of stand up here and kind of take the questions as they go. The room wasn't great. We're having a question. Yeah, the first question. And then the microphones are out there. And there's some questions online.
We've got a lot of questions.
Hi. So the first question is there any reason someone would not want to ask for neoadjuvant immunotherapy versus adjuvant? This is sort of surrounding the operative treatment period.
No, it's a good question. I think with this data that's evolved, I think that the clinicians are very excited about neoadjuvant therapy. So if someone comes to us and we feel like their tumor would be a good fit for this approach, we certainly recommend it unless we have a worry about side effects of the drugs. Perhaps if someone has an autoimmune condition or something that might make giving these drugs a bit more challenging. But I think outside of that, we're very eager to use neoadjuvant therapy. And potentially, again, that sandwich approach with adjuvant therapy versus adjuvant therapy alone.
I think maybe one other comment, it's just, so so stage 3 melanoma also involves all the patients that only have melanoma in the central lymph node, right? So that, and which is actually, I couldn't recall like what the intent is, but it's probably like half, right?
Right, so
For those, you can't really do neoadjuvant right now, although I do not where you know that somebody has stage 3 patient, because typically those patients, they have the surgery and then you find out they have stage 3, but then by definition, you can actually not do neoadjuvant, right?
no, agree. It's a distinct population where we use these approaches, that it's often someone like Dr. Cohen who might meet the patient and feel a lymph node on exam. We do scans and realize it's just simply relegated to the lymph nodes, but the lymph node is bulky. And that would be someone, and bulky is kind of a mark, something we can see or feel. And that's where we're really trying to tailor this approach. But exactly as Dr. Ott said, and Dr. Cohen kind of walked us through those earlier stage 2 and stage 3 were just the microscopic cells. That's really where we're still thinking about adjuvant.
Okay, so our next question is, in the treatment of metastatic melanoma, stage 4, using INO plus Nivo, is a booster required months or years after the initial therapy?
I would say we'll cover that in the next session, right? Because we haven't even done stage 4. I mean, I can like, or should we just, I don't know, I feel like we haven't even talked about like stage 4 at all. But
Next question.
the short answer is basically no, right? No booster.
So this question is in relation to your current use of the vaccine. So is the personalized vaccine for stage 3 and nivolumab only used when there's a tumor, or is it used sort of as a standard of care across the board? Or can it be used as a standard of care?
Yeah, I should have made that more clear. So it's basically what we consider it investigational. So there is there were our initial studies, but the reason, as I mentioned, this is so exciting is there's actually a much larger study, but even that larger study is still relatively small. So it's a phase 2 study, 150 patients. And what's happening now is that there are actually phase 3 studies that already have started that will test like hundreds of patients. And we don't know right now whether the FDA will or will not approve the vaccines based on the phase 2 data. So the company Moderna has applied for that, but it's not clear. So certainly they do a phase 3 study. So one would think that we'll probably have to wait for the phase 3 data. But the short answer is like it's really not available as a standard of care. It's like it is available on, but it is actually available for many patients and will be like fairly soon on these clinical trials.
And I will just make one comment too. I think we're all excited about neoadjuvant. That is yet to be kind of FDA approved, but we expect approval soon. And we have many clinical trials at both Dana-Farber, MGH, and really across the country and globe looking at these approaches.
All right, so this is a bit of a broader question, but when or who qualifies for vaccines? So when, during, I guess, treatment or diagnosis?
So no one really qualifies now for standard of care, right? So it comes down to the eligibility criteria of the studies that are ongoing. And that varies as like studies just typically do. So there have been stage 4 studies. That actually was a stage 4 study that at least MJ, I don't think we ever opened it, right? But you guys certainly had a pretty important role, is actually So the data that we have now is like from Moderna, but BioNTech also had a study where they tested Keytruda in combination with a personalized vaccine in where we say first line patients. We actually have not seen the data yet. So just goes to say that right now we don't even know whether it's just stage 3 or stage 4. A lot of people now, based on the stage 3 trial, of course, think like, well, you should really do it in the stage 3 setting. But I would say that question is like not settled. There's certainly actually vaccine data, even in melanoma. And I really focused on the neoantigens today, but there's actually a study from BioNTech that used non-neoantigens, that used actually sort of off-the-shelf vaccine using their RNA technology. And they showed actually pretty nice responses in a small study. So I would not quite give up yet on this playing a role in the stage 4 setting, but sort of the broader investigation now is in stage 3.
What systemic adjuvant or neoadjuvant CAR T therapies are available for melanoma, and when would you consider that? And would you consider that in different types of melanoma versus like the skin or like the vulva or different areas of the body?
So CAR T cell is not available for melanoma. So we'll talk. Dr. Buchbinder will talk about TIL later. That's exciting. I think whoever asked the question, I think they should maybe wait for that talk. But CAR T cell is like not that's very far from the clinic, unfortunately, in solid tumors. There's like certainly investigational efforts. It's a quite different approach. As a T cell believer, it's like so it's basically so that's basically these like the way it works. It's more. It sort of simplifies a little bit like this whole complexity that I talked to you about, where you and that's like so the reason why this is like very exciting for hematologic malignancies is because those hematologic malignancies have uniform antigens like CD20 or CD21. So basically, all the malignant cancer cells have one antigen, and the therapy basically uses something that's not the T cell receptor, but a different receptor that doesn't have this complexity of what I mentioned, right? The transplant and the diversity. And you can basically just take the cells, you plug these receptors in there, and those therapies are ready to go for all the patients, which is great, but really so far has only worked for mainly hematologic malignancies. Maybe that was a long answer for it, but it's just like there's a lot of, I feel that's a little bit like the world that we live in, right? So lots of things get reported in the media, and then somebody may just say, like, and I've actually made that personal experience too. Like I give an interview to like a reporter, and then I say something about vaccine, and then like in the article they say like, oh, this is like super promising for this and that. I'm like, well, wait a minute, that's not actually what I said. So just apologize for that.
And can you comment on the potential role of blood-based biopsies for melanoma detection and follow-up?
Who wants to take that one?
Well, I think this is certainly an area where we're all invested. Can we find biomarkers to help, again, identify which patients, particularly if we're thinking about this early stage space, can we find ways to identify perhaps cells that are remaining after surgery, those microscopic cells? And that's one area where we're thinking about non-invasive blood-based biomarkers, looking for what's called circulating tumor DNA. So can we take a blood sample from a patient after Dr. Cohen is operated to identify, are there residual cells, and does that mean that that patient would certainly benefit from additional therapy after to hopefully rid the body of them? I think another area that we're certainly trying to utilize this technology is actually to track how tumors are responding. So yes, we have scans, but they're not perfect. They can't really get down to the level of these microscopic cells. So can we utilize this approach, even perhaps when we're giving those first 3 cycles of neoadjuvant therapy, and trend what's called that circulating tumor DNA to understand if we're having a response? And this is something that is not yet standard, but it's something that I think we're all invested in terms of clinical research and trying to help us understand. So biomarkers, I think, is an ongoing effort across the board.
This is sort of a follow-up question in relation to that. Is there any way that, is there any reason that a patient would or would not consider tests like these, like the circulating tumor DNA test?
I think it's just that right now they're not kind of companion tools that we're using in a standard approach. So I think we're very, again, I think Dr. Cohen mentioned it, we're very grateful to how generous patients are with respect to participating in clinical trials and also these, what we call kind of biobanking trials, where they allow us to look at things in the blood and then the tumor. So many are very apt to think about helping us understand, but it's not yet standard.
Let me just add some, maybe to explain like why that is, right? Because it seems intuitive, right? So why would I not do it? But what typically is the problem is that's not yet prospectively analyzed. So when we say, what we mean by that is like, what you really need to do in order to know whether this helps with decision-making is actually incorporating in a study where you follow patients and you can ideally even randomize, not necessarily, but you basically make you do decision making based on those on the information. Because I think the most important thing is like you get it, but then what do you do with it, right? So, but you need data that actually tell you what you should do or should not do. And oftentimes like there's like this disconnect. There's like this cool test. There's oftentimes, unfortunately, there's also financial like interest, right? A company may have a test and they're like really interested in getting that into the clinic, but it's difficult and expensive to do these prospective studies. And I'm not saying like we will, I think there's certainly, I'm not saying it's not useful in specific situations, but it's certainly not, oftentimes it can actually be not useful or even like harmful, right? So if you find you do the ctDNA and like you find something there and you don't really know. So should I like now do more CAT scans or should I not? Like, does it actually even help? It just goes along a little bit like clinical decision making is oftentimes very patient specific, right? And I think it's good to understand that as a patient, that's not just because you read something somewhere and it's like, oh, this should be done somewhere. It should be done for everyone. That doesn't mean it's actually right for you.
Are there any stats available on patients who are in remission after 5 years of the initial infusion therapy, like Keytruda, who have experienced a recurrence?
So it's probably a stage 3 question, right? So typically when I don't know, I don't look for it. Okay. But basically, so what we typically follow patients for 5 years with stage 3. And the reason for that is that we see most of the recurrence during that time. And in fact, most of the recurrence actually happen in the first 2 to 3 years, and 5 years sort of extra. But it doesn't mean that that can absolutely not happen, right? So sometimes it does. It really comes down to numbers and statistics, right? So it becomes much less likely, not completely unlikely.
This question is in relation to the vaccine. Do these vaccines have any notable side effects? And especially if you have a BRAF mutation, would you use this personalized vaccine only if there is a visible or identified tumor, or if there were residual like microscopic tumor cells?
So I think I sort of talked about this already. It really depends. Right now, it's not even approved, so we don't have that option in the clinic. Depends on the trial, and I think we don't have an answer to the question whether we should use it in stage 4, stage 3, or like what the ideal setting is. I mean, if you ask me like what's the ideal setting, it's probably actually the neoadjuvant setting, right? Ideally, you would want to give a vaccine before you do the surgery, and you want to give like vaccine first and then PD-1 inhibition. And so, and that really goes more one of the challenges that we have in the field right now is that we have data that tell us neoadjuvant is great, and we also have data that vaccines are great, but the neoadjuvant the two cannot be combined right now. And there's actually even the clinical trials that are being designed right now are not addressing this. The specific with the BRAF, absolutely, I would not make any distinction. So we basically, when you talk about immunotherapy, there's some data that patients with the BRAF mutation actually respond better to combination checkpoint inhibition, but it's not something that we typically use in the clinic, those data.
Okay, so we've talked a lot about like different new sort of like neoantigen treatments, or neoadjuvant treatments, but how effective is radiation against bone and tissue melanoma? More of the traditional.
Right. How effective is radiation against what tissue?
bone and tissue melanoma.
So so basically, radiation is actually not used. Well, maybe I should say so. If you had asked the question maybe 5 or 8 years ago, I would say like patients that had high recurrence risk in the lymph node basin would typically get like radiation as part of their like curative therapy. But as we have these better adjuvant therapies, actually we use it less and less. That doesn't mean that it's never used. For example, like for head and neck melanomas that are very aggressive, right? So sometimes you have a patient with a head and neck melanoma who has like 10 metastatic lymph nodes. Certainly we have discussion whether radiation could be used as like an additional therapy. But there has been a study from Australia that was reported like 7 or 8 years ago, where they looked into this, where they basically had patients receive radiation to the lymph node basins versus not, and they could show that they could prevent recurrences in the lymph node in some patients or in a subset of patients, but the survival was not different. And so typically in the adjuvant world, when we have survival data, we actually think that those survival data are the most important, which is exactly kind of the reason why, as Dr. Cohen explained to you, right, based on the MSLT2 study, we no longer do completion lymph node dissection, which is like really, that's great, right? And there's a lot of like that's an important element of oncology science and research, is actually to, escalate what we can, but also de-escalate and saying like, well, if a treatment doesn't really benefit and only causes toxicity, it's great not to have to do it. And I tell patients that, right? So I feel it's almost like a little bit underreported, right? So, and of course it has a huge impact on the surgeons. So depending on, anyway.
I want to put in a little caveat there, because I think we're focusing a lot on cutaneous melanoma. There are certain other places where radiation has a huge role. So in the treating of primary uveal melanomas, unfortunately, a lot of it is still series data, but there is some data for the role in mucosal melanoma in treating the local area after resection in certain mucosal melanomas. And radiation can be used to control things like pain from bone metastasis, or potentially in combination with some of the therapies you're hearing about. So just wanted to put in that little plug.
Yeah, and I was gonna add also, sometimes if something is borderline resectable, we'll do anything we can to get it a little smaller so that we can resect it, whether it's a systemic therapy or radiation sometimes.
This is more of an epidemiology question. Is the prevalence of melanoma increasing in younger patients, like patients under 50 years, like some of the other cancers, or do you think this is better detection or a combination?
I would say both. I think we certainly are seeing more patients go to dermatology for that total body skin exam, which is really considered somewhat part of just general healthcare maintenance. But we are seeing increased incidence in melanoma as well across the board in the United States, as well as in kind of younger patients. The clear answer as to why, I don't think we quite really know yet. But I think it just emphasizes the importance of seeing our dermatology, working closely with our dermatology colleagues.
When can a patient say that they no longer have melanoma? What clinical threshold has to be met?
I think it's somewhat always challenging for us to say. I mean, like Dr. Ott mentioned, the goal is, particularly when we're using these immunotherapies, again, our hope is if someone has an early stage resectable disease, surgery in and of itself may again cure the patient. And when we're using drugs, particularly immunotherapy, the beauty of them is not only their ability to act in the here and now, but to generate that durable response. So 2 years, 3 years, 5 years, we're still disease free. And like Dr. Ott mentioned, we're often doing scans kind of up to that point for these higher risk resectable tumors. And I think when we get to that point and we see no evidence of melanoma recurring, we're very hopeful that we have achieved cure. I think there are kind of rare cases where we see changes even after that. So we still do follow and check in, but I think we're hopeful that whenever we're using these medications and working in a multimodality field, that we're offering each patient the best chance for cure.
is the staging for non-cutaneous melanomas the same as the one for cutaneous melanomas for example, like mucosal melanomas, like uveal melanoma?
I think in general, when we think about staging, it is really focused on kind of the size of the primary tumor, the presence or absence of regional or nearby lymph node involvement, and then the presence or absence of disease outside. So I think in the most kind of Cliff Note version, yes.
So do treatments like methotrexate or anything else counteract sort of the like Nivo or Yeravoy type treatments?
I think these are really good questions. And obviously we know that people may need to be on drugs that suppress the immune system. Autoimmune disease is a very common thing that we see. We know autoimmune disease, there is an association potentially with the development of malignancies like melanoma. And we certainly want to do everything that we can, again, to improve quality of life. So we work with whomever is prescribing to say, how is this agent being tolerated? How necessary is the medication? If we can kind of diminish some immunosuppression that people may be on, we do think about it, but we certainly can give these medications while, meaning the immunotherapy drugs, while patients may still be receiving medications like methotrexate and still see good response.
So I think we're going to take a little break now. I know there are still a lot of questions, and I'm not sure how this happens, but AIM is going to actually make sure to answer all of those questions, have us and other MDs kind of weigh in on those answers. And if there's more time during the next Q&A, we will definitely ask them. So please take a break. Restrooms are around the corner. There's food in the back. Thank you. Yeah.
I wasn't sure. Unfortunately, I also want to see okay. You actually have to. We're gonna go to
First time. Particularly there's folks that ask.
Yeah.
Oh, yeah, they're so, they're trying to understand. It's better to do a next. So I think there's another area. After surgery.
Oh, you got to.
Better than another.
Yeah.
Very small. That's really fun. Yeah.
You can see. Yeah.
We need to move the slides to the right, and we need to mute the mic. Their mic is not muted. That's what it means to have a man. Oh.
No, I want to create that.
All right, I think we are gonna get back started. I know that was a super quick break, but wanted to move on to the second half of our presentation. I gotta get Patrick's attention. Patrick. Do I do all right, everybody. So we're gonna get started. I'll get a little louder. That's what I'll do. So, all right. So we're gonna move on to the second half. We've talked a lot about early stage melanoma, neoadjuvant, adjuvant, surgery, vaccines, and kind of what's happening in those spaces. With the second half, we're going to move a bit more into metastatic melanoma. So the world of metastatic melanoma has had some amazing advances over the last many years. At this point, most of our patients are receiving some sort of immune therapy as their first line of treatment. Very often combination therapies. So therapies, ipilimumab and nivolumab, or nivolumab and relatlimab, which is one of the newer therapies. Unfortunately, even with these therapies, they don't work all the time. And even with ipilimumab and nivolumab, which is kind of the one that has the highest efficacy rate, when you look out at 5 years, about 60% of patients have had their melanoma come back. And so over the course of that 5 years. And so the issue is that we still really need new therapies. So we have immune therapies. You also heard a little bit about targeted therapies, particularly against BRAF patients whose melanoma has a BRAF mutation. And these are different tools we have, but there's a lot of work going on kind of building on these, looking at new ways to harness the immune system to fight the melanoma. And then also in those targeted therapy spaces, looking at new mutations within the melanoma and new things to target. So as these therapies have been developed, we've got a better sense of kind of where to start with melanoma. And I think Dr. Sullivan may mention some of these therapies as well, but what we really need to do is kind of what's next, what's coming, what other things can we do when those therapies fail. And so we're going to talk a little about that, about some of the kind of exciting things that we're seeing in development, some of the things that questions were raised on, like novel immunotherapies and cellular therapies. And so with that, I want to introduce Dr. Ryan Sullivan. I have known him a long time, and I'm so thrilled, as always, to see him over here. He comes from Mass General Hospital, where he works as a medical oncologist, has a lot of titles now. So he's the melanoma he's the associate director of the melanoma program. He's a member of the Termier Center for Targeted Therapy at Mass General Cancer Center, associate professor at Harvard Medical School, and is very active clinically, both working in novel therapies for melanoma, immunotherapy toxicity, as well as testing new drugs. So with that, I'll hand it over to Dr. Sullivan.
Get the picture of me off as quickly as possible. I'm sure I'm better in person, but I know I'm not photogenic. So in any event, it's a pleasure to be here. Thank you, Dr. Buchbinder, and the folks at AIM at Melanoma for allowing me to spend some time with you on a Saturday morning. I'm grateful for all of you here and all of you online for sharing some of your weekend with us. So I am tasked with talking about new therapies. And I will do so, and I will promise that bispecific therapies will be defined at some point in the next 5 minutes or so. Here are my relevant disclosures. None of those actually make bispecific therapies, I don't think. Okay, so advanced melanoma treatment landscape. So this is, you saw something similar to this with Dr. Meridian's talk, but I want to point you to the far left. The far left has this 4-letter thing called DTIC. That another word for that is dacarbazine. It's a standard chemotherapy that I think was approved essentially by default because nothing had been approved for melanoma in the mid-70s, and so this was approved. You can see skips of time. And then high-dose IL-2, that was about 20 years between dacarbazine being approved and high-dose interleukin-2 being approved. high-dose interleukin-2 is really sort of the first modern immunotherapy, and helped about 10%, 10 to 15% of patients with metastatic melanoma and a similar percentage patients with advanced kidney cancer. But most patients didn't benefit, and many patients weren't candidates for it because of toxicity. And then you see another skip of time, and there was about 15 or 16 years between high-dose interleukin-2 being approved, and then the dual approval for ipilimumab and bemarituzumab in 2011, really starting this amazing decade of progress. Now, in fairness, there were a few amazing decades of scientific progress without clinical progress that was happening at the same time. And when we think about the treatments, this has already been distinguished, but some of these treatments are targeting very specifically this mutation called BRAF, that about half of our patients, their tumors harbor a mutation in BRAF, and we can use therapies that target that. The other half of patients don't have that. Interestingly, that in the early studies, it didn't seem like patients with BRAF mutations did any less well with the immunotherapy than patients who didn't have a BRAF mutation. And so one of the things that would happen at meetings, gosh, for probably from 2009 to about 2020, when the pandemic hit, is that there'd be these debate sessions. And you say, what do we do first? Do we do BRAF targeted therapy first, or do we do immunotherapy first? And then ultimately, a few trials were run, and it proved that we should be, for most patients, even if they have a BRAF mutation, starting with immune therapy. Because I'm going to be talking about novel immune therapies, I might as well talk about non-novel immune therapies, which actually still are pretty novel. Where's the mouse? Oh, got it. Okay, starting to have performance anxiety. So ipilimumab is really novel. So even though it's been approved for almost 15 years and we rarely use it on its own, this is a drug that targets the way that immune cells get educated to go attack stuff. So all of us, I think Dr. Ott said something about being a T-cell enthusiast. We're not T-cell enthusiasts, we're T-cell evangelists. Like here to say that T-cells are really important and we should be doing everything we can to make T-cells more effective at attacking cancer. Ipilimumab helps in this education phase. So essentially, the way our immune system works is if every T-cell receptor could recognize what it's can recognize and activated, we wouldn't live very long. We would die of autoimmunity probably as soon as we started getting exposed to the outside world. And in fact, if you knock out CTLA-4 in mice, that's exactly what happens. They form perfectly good-looking mice, babies, and then they die within weeks because they can't handle the world, because they just attack all of their body parts. The T cells attack all their body parts. So it's a critical point of regulation of the immune system. And so one of the ways, the way that this sort of happens, if this regulation happens, is when you're educating an immune cell to go and attack something. There's a lot of people like to think of this as a car, and that you're hitting the gas. And the other thing that the immune system does is it immediately breaks. Now, some of those cells get out and they can attack what they've sort of been educated to attack, but then the immune system is breaking at the same time. And so you're sort of gas, brake, gas, brake, gas, brake, which is actually exactly like driving with my father-in-law, because he's a terrible driver, but he's a nice guy. And so I do the driving if I'm in a car with him. But that's like really novel. And it changed the way we thought about treating cancer. Other areas, other checkpoints of the immune system were discovered soon after. PD-1 and nivolumab and pembrolizumab are PD-1 blockers. These actually, PD-1's a receptor. Receptors are proteins that are on the surface of cells that can capture stuff. And when they capture it, it's like, boop, and then something happens. Well, when PD-1 captures whatever it binds to, it tends to shut down the cell. And so if these active immune cells get into the tumor environment and are looking to sort of seek and destroy cancer cells, but it binds to the thing that it's kind of built to bind to, it shuts the cell down. And so blocking that interaction can lead to more effective navigation and thus attack of those active immune cells in the cancer. The other new, actually atezolizumab's up there, that's a PD-L1 blocker, which is actually blocking the binder of PD-1. And then Nivo and relatlimab. Relatlimab's actually a blocker that essentially is an indicator that the T cell is tired. The immunologic scientifically word for T cells that are tired are exhausted T cells, which is a big word. So if you want me to explain that to you later, I can in the next break. But basically, not only is this target, which is called LAG3, a marker of exhaustion, if you block it, it tends to reverse the exhaustion very often. And so what we end up having are a number of immune therapies. We have ipilimumab, we have nivolumab and pembrolizumab. Trials were done. Turns out PD-1 blocking is better than CTLA-4 blocking. So there are trials of Nivo versus Ipi, Pembro versus Ipi, demonstrated the superiority of Pembro and Nivo. Ipi and Nivo together work better, but as was alluded to before, there is a downside to activating the immune system and removing some of the regulatory aspects of the immune system. You can, in fact, have bad side effects, and they're much more common when you give that combination compared to just giving Ipi or just giving Nivo. And then the Nivo plus relatlimab was compared to nivolumab and seems to be better without as robust an increase in side effects. So that's 15 years of drug development in 5 minutes. In the red are the BRAF targeted therapies, which again, we often use in patients who have BRAF mutations, but we tend not to use it in the setting where a patient is initially diagnosed with advanced, which means either unresectable or widely metastatic disease. So what are the unmet needs? I think it's important to note that all of what I just talked about is mostly based on data in the frontline setting of advanced disease, meaning patients who are recently diagnosed with metastatic melanoma. Almost all those patients have cutaneous melanoma, which is the melanomas that arise out of the skin, as opposed to melanomas that arise on mucosal surfaces or melanomas that arise in the eye. And most of the data that was generated are in patients who were treated before the advent of the development of the adjuvant and neoadjuvant therapies that were described by Dr. Mouradian. And so the challenge is this data is cool. The therapies are effective. They don't help everybody. And trying to understand what do we do when these therapies aren't effective is sort of one of the great unmet needs that we need to sort out over the coming years and decades. So first of all, second and third line therapies after using all of these amazing immunotherapies is a critical unmet need. Honestly, understanding whom we should offer which immune therapies in the initial setting is an important unmet need. I'm not going to talk at all about that today. And then better therapies for uveal melanoma, which are melanomas that arise out of the aspects of the eye, acral melanomas, which are skin melanomas, but they're on the palms, the nail beds, and the soles, and they have a slightly different biology and aggressiveness than garden variety skin melanoma. And then the mucosal melanomas, which are melanomas that arise out of the lining surface. And I'll talk a little bit about uveal melanoma when I'm talking about bispecific therapies. And I did the same slide twice, sorry. Although this one's different because it's got yellow. All right, so let's talk about the basics of uveal melanoma. So melanoma is a bad disease. We have better therapies for it, but it's a bad disease. You don't need a lot of it for it to have a high risk of spread. If you just sort of think about most cancers, we measure the tumors in centimeters. In melanoma, we measure the primary tumors in millimeters. And that's probably all you really need to know about the badness of the melanoma, although you guys are all here, you understand this disease probably better than most. Uveal melanoma is a really bad disease. The reason it's a really bad disease is, yes, you do have pigment cells in the eye, and they can become malignant. And the way that most patients present with uveal melanoma is either they show up for a routine eye exam and somebody says you have a weird looking mole in your eye, or the patients present with vision changes. They're really the only two ways that patients present. The reason it's a bad disease, not only can it impair vision, but it has high rates of metastatic spread, even when the melanoma is very small. And often that metastatic spread involves the liver and bones, which are tricky places to treat. And another reason it's a bad disease is the standard therapies are not as effective as they are in skin melanoma. So I put a little table in there, which is just showing response rates. That's a percentage of patients that have tumor shrinkage that's of a significant amount that we qualified as a response. And the response rates of uveal melanoma compared to CM is cutaneous melanoma is an order of magnitude less for each of the types of therapies we offer, or nearly. Even combination therapy, the rates are a quarter of the rates with skin melanoma. So our standard therapies that have transformed the way we treat melanoma just aren't as effective in this patient population. And to sort of add insult to injury, we don't even have BRAF targeted therapy to offer these patients because there are no BRAF mutations in patients who have uveal melanoma. But we have this drug called tebentafusp, and this was FDA approved in January of 2022. It's FDA approved because it improves overall survival. It actually, at any time point after starting the drug, patients were about twice as likely to be alive if they received tebentafusp and if they were randomized to receive either pembro, ipi, or a chemotherapy, actually dacarbazine. It's a weird drug. We actually don't measure benefit in shrinkage because it doesn't commonly shrink tumors. And we commonly are able to continue treatment after the scans show that scans are growing, or scans are showing the disease is growing, and we get additional benefit. And to the question that somebody asked earlier about blood-based biomarkers, there's actually a lot of data that says because the scans are usually worthless in terms of following, that actually following blood-based biomarkers might be a better approach to monitoring patients who are treated with this therapy. Okay, what the heck is tebentafusp? Let's say it out loud 5 times fast and see who can get it right the 5th time. The obvious answer is an immune mobilizing monoclonal T cell receptor against cancer, right? You guys knew that, obviously, an IMTAC for short. But as a T cell evangelist, I'll walk you through this slide. So the normal T cell receptor, which you heard Dr. Ott mention, recognizes peptide in the context of this thing called HLA. The T cell receptor then activates, and then the T cell can destroy what it's recognizing. When you don't have T cells that you can easily activate, like with immune checkpoint inhibitors, we have to think of different means. And so tebentafusp actually has a T cell receptor as part of its molecule, and it recognizes a peptide. In this case, the peptide is something called GP100, which is commonly expressed in melanoma, almost always expressed in uveal melanoma. And on the other end, this purple thing actually engages with a receptor on a T cell called CD3, and it engages it in such a way that if it does so, it brings the immune cell and the tumor cell together, sort of like evilmatch.com, and it allows that T cell to destroy the cancer cell. And so there's 1, the targeting domain, 2, an effector domain, and that equals bispecific therapy. Only 15 minutes in when I got to it, but so that's cool. Are there any other bispecifics in uveal melanoma? Obviously, if I ask the question, the answer is going to be yes. This is a very similar molecule. It's in fact exactly the same molecule, except instead of the T cell receptor recognizing GP100, it recognizes something called PRAME. And its PRAME is a antigen that's expressed in a lot of different cancer types, including most melanomas. It recognizes it. It has this effector domain that binds to the CD3 receptor, and again, plays evil matchmaking. Does this work? Well, the best data, the earliest data we have suggests that in uveal melanoma, this tebentafusp naive means these are patients who haven't received tebentafusp yet, that the response rate in the early part of the study was 6 patients, suggests that, yeah, it kind of works. And most of these patients are going down on the waterfall plot, as Dr. Ott said, down is good. And so it does look like an active drug in this disease. These are patients who've received tebentafusp, and you actually see some tumor regression in some patients. And so it may have a role there as well. So these are 2 bispecific molecules that have been developed. And in many ways, the first target disease for this is uveal melanoma, because we don't have the effectiveness of our standard immunotherapies for uveal melanoma. But wait, there's more. So this is not to scale. Okay, that blue blob there is only as big as it is because I couldn't figure out how to make it smaller and make the animations work. But that blue blob is a protein called PMEL17, which is expressed on the outside of cancer cells, specifically melanoma cells. DYP688 has a red part, which is an antibody, and a black part, which is a drug that blocks GNAQ and GNA11. And when it goes in, I'll watch this, two parts, so it's bispecific. Look at that. It binds, and then when it binds, it drops its payload that blocks GNAQ and GNA11, and it kills the cell. I'll be here all week, ladies and gentlemen. This is a cool drug. We don't have clinical data that we can share yet, but we're hopeful that there'll be clinical data presented in the next few months with this drug in uveal melanoma, showcasing that it actually might be a new effective approach at managing patients with this disease, but more to come. So those are 3 bispecific molecules in uveal melanoma. Tebentafusp approved, improved survival. It's a thing we're looking to do. It's actually pretty well tolerated once you get through the initial phases of it. IMC F106C is that other one. That's the PRAME directing tebentafusp. It's not tebentafusp, but similar to it. Trials are ongoing, and the data is looking pretty good. And DYP688 is an antibody drug conjugate that's again beginning to look promising. Okay, let's briefly go through here. Tebentafusp again. This bispecific molecule actually can help some patients with skin melanoma. And so this is data of a trial of tebentafusp plus durvalumab, which is an anti-PD-L1 antibody. And this is what's called a spider plot. If there were 8 patients, it would look a lot more like a spider than, dozens of patients where it just looks like a mess. But essentially, down is good still, and continued down is way better. And so the advantage of this plot is I can show you what happens initially. Do patients' tumors grow, or they get smaller? And then how long are they remaining on treatment? And the answer is patients seem to be remaining on treatment, some patients, for quite a long time. This is months, so this is a year. And so if you're on for a year, you're very likely on for 2 years and beyond. There's actually a clinical trial looking at comparing tebentafusp plus a PD-1 inhibitor, and a straight to follow-up trial, which is launched and is open at Dana-Farber. It's open at Mass General. And the cool thing about, and this is in patients who've had immunotherapy already. And then the cool thing is the arm C allows you to go on to a different clinical trial. So if you don't get randomized, if you get randomized to the control arm, you can still get a novel therapy on a clinical trial. So pretty cool trial design. We're excited about that. This PRAME drug seems like it has some activity in skin melanoma too. And there's actually a large trial being launched to look at this in patients with skin melanoma, which is exciting. Any other cool ideas? This is my last couple of slides. So this is cryoablation. If anybody gets the pun, feel free to laugh. If not, I'll tell you about it later. So cryoablation is you actually stick a probe into the tumor and you cool it with freezing stuff. And the thing about freezing a tumor is it actually leads to cool changes in the immune system that probably promotes an anti-tumor response if given in the right way. And this is a trial that actually led by Dr. Moradian. So I'm proud to present it in front of her, although if I do it wrong, she can correct me. But the idea is to make this tumor that's cold go to hot. And in fact, this was a trial where we treated patients with anti-PD-1 antibody therapy. Their tumors were growing, and we just added freezing. We didn't do anything else. It's not like we gave another therapy or a different immune therapy. We continued the immune therapy, and we froze their tumors. And we had 17 patients enrolled, and almost a quarter of them had a response. Now, we didn't analyze the tumor that was being frozen in the response. So this is measuring other disease that's responding. So just by the tumors that weren't shrinking, if you freeze a different tumor, a quarter of the time, other tumors started shrinking. And this is just to show that a lot of these patients that went on, red is like their disease was growing, and they were growing very rapidly right before they went on treatment. And we've had 4 patients remain on either on therapy or continuing with clinical benefit without any other therapies, many over a year and a few over 2 years. And there's actually now a follow-up study looking at IPI, Nivo, and cryo in patients who've been on immune therapy and it wasn't working. Okay, so the summary of bispecific and other approaches, a lot of promising data with Tebentafusp in this PRAME-directing version of Tebentafusp in patients with skin melanoma. Larger trials are being launched and emerging data with a number of intratumoral approaches, including cryoablation. 1 trial complete, data looks strong, 2nd trial is launched. With that, I will end and thank you very much.
So it's okay. So my name is Beth Bookbinder. I'm a melanoma medical oncologist at Dana-Farber. And I specialize in treating patients with melanoma kind of at all levels, work in immunotherapy, targeted therapy, new drugs, and toxicity. And so I am going to talk a little about some of the new exciting cellular therapies. And so if there's one message that you guys really will take from today, it's how much we as medical oncologists in melanoma and immunotherapists adore T cells. And I would argue that it's not just T cells. We like all lymphocytes. We like all of those immune cells that are going in there and attacking the tumor. And, I think I have teenage kids, so I kind of think of them as like the Avengers of the immune system. They're going in and getting those bugs, getting those viruses, bacteria, but then also those tumors. And the good news is when you have a melanoma, that melanoma isn't just melanoma cells. And so what you can see here, these dark things, those are your melanoma cells, but there are also these green and blue. These are those lymphocytes. These are those immune cells that are actually in the tumor already. And very often they're trying to do the job. They're trying to get rid of that melanoma, but they're exhausted. They're trying too hard. They need some help. They need something to kind of keep them going. And immune therapies do that. So the immune checkpoint inhibitors, they really kind of boost them up, help them keep going. But those cells, those are really the powerhouse behind what we need to do to use the immune system to fight cancer. And so we've got a picture of a couple of those, there's Thor and Iron Man getting that tumor right there. And so we need to do things to make those cells stronger. And what cellular therapies are doing is kind of not just working on making those cells stronger, but working on the fact that those are the cells that are the most likely to be able to attack that tumor. Those are the cells that are there. They know that tumor, they're already trying, but they're kind of worn out and not able to do everything they need to do. And so the idea behind cellular, so using TIL therapy or tumor infiltrating lymphocytes is actually trying to make those lymphocytes already in the tumor stronger and giving them back. And so there's several steps involved in this process. The first is actually removing a tumor, because within that tumor, it's got those lymphocytes. So that tumor is removed. And then after that tumor is removed, there's all sorts of steps involved in preparation and treatment of those lymphocytes in order to give them back to fight the melanoma. So surgical removal of a melanoma lesion, that lesion goes to the lab, so that tumor goes to the lab. The melanoma cells are killed and gotten rid of, and the immune cells are fed and grown. And so in the lab, those lymphocytes are grown up. They're given all sorts of food and, ensure, boost, everything they need to get stronger, and are purified, they're treated, they're expanded. And then what happens is they're given, patients come into the hospital and they're given back to the patients. Now, there's a couple steps that happen before this happens. First off, the body sometimes reacts badly to immune cells when they're given back to patients. So a little bit of chemotherapy is given to kind of suppress the immune reaction that the body might have to its own immune cells. So that there's a little bit of chemotherapy that's given. Then those immune cells are given back. So those TILs that have been really fed and grown up are given back. And then following that, there's actually some additional therapy that's given, which is called IL-2. Now, if you remember when you were looking at Dr. Sullivan's slide, IL-2 was a therapy approved a long time ago for melanoma, and actually has some benefit on its own for melanoma. But what it really is it is that gas pedal. It stimulates those immune cells, all of the immune cells in the body, including those TILs, and can really get that immune system going and those lymphocytes going. And so what this therapy, there's many steps involved in this therapy, but the goal of this therapy is to really stimulate those lymphocytes that are already in the tumor, already recognize it, to then go out and fight the melanoma. And this is another kind of schema of the same sort of thing. What I thought was interesting here is you can see this process takes a while. So this is, the tumor is removed, it goes to the lab. There's a whole kind of processing that happens. And here it's, they're saying 22 days before those cells are ready to go back and be infused into a patient. But very similar in terms of the different steps that, have to happen with tumor removal, patients getting a little bit of chemo to kind of set the system up for those lymphocytes to work, and then that infusion followed by that IL-2. And what's been seen with these therapies? So that this is data of a cellular product called lifileucel, which is one of these TIL therapies. And what was done is many patients with melanoma who progressed after other therapies were given this TIL therapy. And there are two cohorts here. It just happens they were run kind of one then the other, but really looking at this green column, there were 153 patients total that were treated with this TIL therapy. And what you can see here is that 31% of them had some reduction of their melanoma. And these are patients that had had many other therapies prior. And in fact, in terms of, there was also 46% that had stable disease. So their melanoma didn't grow, with only 17% really having progression of their melanoma after this therapy. So this is really exciting data, and really shows that this therapy can potentially have some very nice efficacy in patients who've had other therapies before and then are treated with this TIL therapy. What this is, and is looking at the side effects related to that therapy. And this is based on time. So looking at the bottom, and so D14 is day 14. Most of the side effects to this therapy also happened really early on. So they happened when patients were still in the hospital. A lot of them were from the chemotherapy I talked about, or from the IL-2 itself. And so that many of those side effects resolved, and over time, when you're out at month 1, month 2, so further out here, there were very little residual long-term side effects from this therapy. So it was pretty well tolerated. And this is, we talked a little about these waterfall plots, and what these are is they're showing this line at 0 is if the tumor didn't change, then patients stay near zero. Any patient on here where the tumor shrunk, it goes downward. Any patient here where it grew, the line goes upward. And so what you can see here is that a lot of these patients had very nice reduction in their melanoma with this TIL therapy. And so all of the blues here are those who had a partial response. The green are patients where their melanoma disappeared entirely. And so very exciting data in terms of what we're seeing with TIL therapy in melanoma. This is a complicated figure. I think I could hang it on my wall. It's so pretty, but what it is showing is the different lines of therapy that these patients had before going on TIL therapy. And you can see out here, there's one patient that had 10 prior treatments before going on TIL therapy. And so what it shows is that this is a therapy that can be used even after other therapies, other immune therapies, other targeted therapies. So the red line here is targeted therapies, most likely BRAF targeted therapies. The green line is green lines or immunotherapy combinations or immunotherapy with targeted therapy. And you can see that many of these patients received many different therapies before going on TIL, and yet we still saw a pretty good response in all of the patients that were treated. So this is really exciting in terms of the fact that TIL is therapy, because it can be quite hard with the chemo and the IL-2 after, is something that could even be done after other therapies and still have some benefit. In addition, what is really been seen with these TIL therapies is that when patients respond, that response continues. So we think of this in terms of duration of response. So if something works, but it only works for a month or two, how excited are we about that? Probably not so much, but if it works and keeps working, so it keeps the melanoma from growing like a lot of our other immunotherapies do, then that really gets us excited. And so with TIL therapy, that was another thing that was seen, is that in patients who responded well to it, it continued to work. And so that's very exciting. Now, the big question with TIL therapy, though, is how does it compare to other standard therapies that we might be thinking about, so that we can think about, when do we do it? How do we treat patients with it? And in all of the studies I showed you so far, or the data I showed you so far, it was just everybody was treated with TILs. There was no comparison. And so most of our trials are done where we compare it against something else. And so in this case, this trial was done that was comparing TIL therapy versus ipilimumab in patients whose melanoma had grown after receiving PD-1 inhibition. So either nivolumab or pembrolizumab, and then needed another therapy. Their tumor didn't respond to that PD-1 inhibition. This trial randomized patients, so half the patients got TIL therapy, half the patients got ipilimumab. Now, of note, you've heard of us talk a bunch about how these days we're mostly using combination immunotherapies. This was a trial done before that was done as much. So most of the patients did just receive one drug. But what was seen is that in those patients who received TIL, so this is this red line, that they did better than those patients treated with ipilimumab alone in terms of the time to their melanoma growing. So you've been looking at a bunch of curves with the adjuvant therapy that are looking at recurrence-free survival. So how long until the cancer comes back? And every time someone's cancer comes back, that curve drops a little. This is how long until the cancer grows. And unfortunately, we've still got a lot of work to do, but what it shows is that TIL therapy in this setting can be better than ipilimumab. So in the second line setting, can improve upon the growth of that melanoma. So this is the responses, and here you can see that there was so the response rate was 48% in there, 49% really in the TILs, and 21% in the ipilimumab treated patients. And once again, here are the waterfall plots showing quite a few more responses in those patients treated with TILs as compared to those treated with ipilimumab. And so this study really kind of established that TIL is potentially a great therapy after frontline immunotherapy. And hopefully it will be something that we see actually entering into our standard of care in the next many months. Unfortunately, the FDA actually, so the lifileucel, the first therapy I showed you, that was up for FDA review and got delayed. It was supposed to be reviewed by November. They just delayed that back to February due to staffing issues. So hopefully this will be coming. There are many clinical trials of this, but definitely an area where we're super excited to be working and super excited to be hopefully soon being able to offer this as a therapy in melanoma. Now, there are also a lot of efforts, and I really just put this up as kind of a placeholder to talk about. There are tons of efforts trying to make these TIL therapies better. So we talked about how, you know, we're taking them out of the body. These are the lymphocytes. These are the fighters. What this is doing is trying to give them a stronger weapon. So give them something on the surface that's going to make them better, make them work even, you know, better against the melanoma with all sorts of new technologies. And so this is one company that's doing this with CRISPR, which is this new scientific technique where you can alter cells. But there are many companies out there that are doing all sorts of things to try and make this happen. And so TILs, place to watch, hopefully approved within the next, now I guess we're looking 6 months, but also an area where we're going to see a lot more work done because there's going to be efforts to make these better and make these stronger. So CAR T cells came up, and I smiled because I do have a couple slides about CAR T cells. As Dr. Ott mentioned, still too early in melanoma. We don't have any CAR T cell therapies yet, but I do hope that maybe we will. But I wanted to talk about what is a CAR T cell, because a lot of people hear it, they're asking what it is, and so I want to explain what this is. So CAR stands for chimeric antigen receptor. And so this is part antibody molecule, part T cell activating molecule. And so you've heard a bunch about how there are different things that activate the T cells. And you heard from Dr. Sullivan about these bispecifics that kind of bind, that have signals that kind of pull in the T cell. Here, that signal to activate the T cell is actually within this molecule. And there is a thing on the surface that allows that T cell to then recognize something specific on a cancer cell. So basically a honing mechanism that's put onto that T cell so that it can then recognize cells that are abnormal. Now, you can see here, there's all sorts of different ways these are built up. And what is happening is that T cells are taken out. So T cells are taken out of patients, actually, in this case, not from tumors, but actually from the blood. Those T cells are treated so that they then have these molecules on their surfaces and then given back to patients. And so this is an area that has really seen amazing success in the hematologic malignancies and the treatment of lymphoma, leukemia, but is still being developed. There's still a lot to be done here before we can use this in melanoma, but who knows? We're hoping soon that maybe some CAR T cell therapies will be developed in melanoma. There's a lot of other ways that cellular therapies are being used, but these are some of them. So here is just a little bit about that CAR T cell. How is, what is it and how is it made? And so the T cells are collected. There is this transfection technique where DNA is given into the cell so that that T cell itself then produces this CAR protein on its surface, and then that's given back to patients. And here are a couple pictures of what some of these look like that have been kind of approved or being used now in patients, all in large B-cell lymphoma. But this is Yescarta, which is one of the ones that's approved, Kymriah and Lysocell. So these are CAR T products that are currently in use and have been shown to be really effective. And so I'm not going to go through this, but just in lymphoma have remission in about 40% of patients. So really, really exciting. One of the issues with any cellular therapy, and also in particular with CAR T-cell therapies, is that there can be a fair amount of side effects associated with this therapy. So there's something called cytokine release syndrome, where when these cells are given back, they lead to such a robust immune response within the whole body that they produce a ton of these cytokines and lead to the body almost thinking it's fighting a really bad infection. We can see this with some other immunotherapies as well. And then also there are some issues with neurotoxicity where patients can become very confused on these therapies. So one of the biggest take homes here is that there is tons of work going on developing all sorts of different techniques and technologies within immunotherapy, and that these range from things like what we've heard about today, so the cancer vaccines. There's some work going on in cytokine therapies. What cytokines are is that IL-2, those things that kind of feed the immune system and boost it. So adoptive cell transfer, so this is what these TIL therapies are, is actually taking those immune cells and giving them back or altering them in some way. Immune checkpoint inhibitors are our traditional, the ipilimumab, nivolumab, pembrolizumab, atezolizumab, cemiplimab, these drugs that basically take off those brakes on the immune system and allow those immune cells to attack the cancer. And then there also is some effort in terms of using oncolytic viruses, things that will get in there and make the immune system think that a tumor is infected to really boost the response within that immune system. So what Dr. Ott referred to, which is when you have a tumor that doesn't have a lot of immune cells in there, getting them in there by kind of tricking it and making it think there's something bad going on. So tons of areas where we're developing new treatments, new technologies, and new things for melanoma therapy and for therapy for cancer in general. So with that, I am going to end.
Okay, while Alex and Eric collect the many questions I know are all over the room. I pull this out. And I have
Okay. Oh, should I go ahead with our first?
I have a little piece that I want to do on AMIT melanoma, and then I know that we'll have another robust question and answer period. Thank you so much to our panelists for your absolutely fantastic presentations. I do want to just speak for you just a moment about our foundation. If you're not familiar with AMIT melanoma, we were founded 20 years ago by Val Guild when her 25-year-old daughter was diagnosed with melanoma and then subsequently lost her life to melanoma 9 months later. And then it became Val's absolute mission to do two things. One, to find a cure for melanoma in our lifetime. We are doing that by raising money and then funding tissue banks that are all over the country. And then in addition to that, we want to support people who are living with melanoma. And that largely comes through education. I hope that our presenters will agree with me that we do not want you to make an appointment with Dr. Google. And so therefore, we would like to point you to AMIT Melanoma's website. We try to make sure that the information that you find on there is up to date, relevant, and reliable. By far, our most frequently, visited pages are the pages on staging and their relevant treatment, also on side effects. And then in addition to that, we have a brand new section on clinical trials, what they are, the various types, so that if you have an interest in participating in a clinical trial, you'll have a better understanding of what is accomplished through clinical trials. One of the things that we're very proud of is a new set of Melanoma 101 videos. The first three are called I've Been Diagnosed with Melanoma, Now What? They're absolutely fantastic. The third one is geared towards caregivers, because we know that caregivers are very much involved in that treatment journey. We have a program called Ask a Medical Expert. Melissa Wilson, who is an oncology PA working out of Pittsburgh, she will answer your questions. For those people whose questions don't get answered today, I encourage you please to go to our website and fill out that form, and Melissa will do her very best to answer your question. Her goal is not to change your plan of care, is to help you make sure that you understand what your next steps are and why. Because she, has been asked often the same questions over and over again, she decided to make a series of webinars called From the Clinic to the Living Room. So these are the most frequently asked questions from that Ask a Medical Expert. We encourage you to watch those. They're absolutely wonderful. And I encourage you to go to our website and look at our symposiums. With AIM Melanoma co-hosts 10 symposiums a year. Just like the presentations today, the presentations are taken, edited, divided by topic, and then put back on our website. So you can go back as far as 5 years and look at presentations from cancer centers all across the country. Lastly, I want to tell you about our podcast called Beyond the Clinic. It is hosted by Ray Liu, who is an oncologist with Kaiser Permanente. The things that we cover in Beyond the Clinic are the kinds of things you may not talk about in a typical visit with your doctor. There are things like exercise or being friends with the sun again, those kinds of things. So please go listen to those. We have lots of wonderful experts on those podcasts. Then the last thing I want to talk to you about is Peer Connect. Peer Connect is a one-on-one mentorship program. We have volunteers who have gone through a treatment journey. They're on the other side of it, and they have stepped forward and trained to be mentors to people who are newly diagnosed. So if you are new in this journey and you would like to have someone to come into your circle of trust, somebody who is empathetic and understands what you're feeling, please reach out to AIM and we will connect you with a mentor. And also, if you are on the other side of your treatment journey and you would be willing to walk along somebody, please reach out to us. So I want to put up this is my contact slide so that you can reach out to AIM with questions about any of the things that I've just covered or anything else that you may wonder if we have a resource for you. Being together here today is very powerful. That's what Peer Connect is about, is really that opportunity to be with people that understand what you're going through, what you're living through, and share your passion for curing melanoma and for finding effective treatments. I want, in my closing, to introduce you to Tom. Tom is a melanoma survivor. He's a Peer Connect mentor. And last year, he lives right here in Boston. And last year, he decided that he was going to start a Steps Against Melanoma walk. I'm going to let Tom speak for himself. So I'm going to switch slides and then I'm going to speak to the sky and say, Eric, go. Uh-oh.
Hey everyone, thank you for attending the symposium. Sorry I couldn't be there live. I have a family trip I'm going to be at, or I currently am at. So just want to take a few minutes, talk about my cancer journey, my work with AIM at Melanoma, in an upcoming event we have coming up next weekend. So first, I'm a Boston guy. I grew up in Revere. I live in Chelmsford, married almost 7 years, got 2 little ones at home, a 3 and a 7-year-old. So my melanoma story, as long as I can remember, going back to, my preteen years, I would always get skin checks. And part of that was because of a family history. I had an uncle who had melanoma. My mom went through 9 different cancer battles, non-melanoma related, over a 12-year period. So everything went smooth for a lot of years. In 2013, at the age of 34, I went in for a typical routine skin check. Had one mole they were going to biopsy. I had a spot on my stomach that was itchy. perfectly circular, didn't meet any of the criteria of the ABCDEs of melanoma. And I just asked the doctor, hey, can you just please biopsy it? And 2 weeks later, sitting in a work training, remember getting a phone call from my doctor saying, hey, call me on my cell phone when you get a chance. First sign that things weren't great. So went back in, found out it was a stage 0 melanoma. So very lucky that we caught it early. Very lucky that I advocated to say, please biopsy that. In 2014, so the year after, I went in for some genetic testing, just given our family history, the relatively young age at my first melanoma, and I found out I had a genetic mutation, putting me at high risk for melanoma, kidney cancer, and pancreatic cancer. As a kid, I always had those dreams of, the cool genetic mutations you see in the movies. Mine wasn't as cool, but, it gives me a little bit of a heads up of what might come down the road. Went 7-8 years with pretty routine skin checks, endoscopies, and MRIs. 2021, had a random pink spot show up on my right arm. Went in, doctor said, yeah, that looks suspicious. They biopsied it. It was a stage 1A melanoma. That one hit a little bit differently. At that point, my first one, I was single guy, no kids. Now I have 2 little ones at home and really struggled with that diagnosis and what it could be in the future for me and my family. And that's when I got in touch with AIM at Melanoma. I came across them just through an internet search. They offered up mentorship programs, and I talked to a few folks that really helped me get my mind in a better place and just really understand to live in the moment and not let these diagnoses impact me as much as they could. In those conversations, I realized that I could bring something to the table as well to help mentor folks who are newly diagnosed with young families. And that started my journey with AIM. I was talking to a couple of folks there about a charity golf tournament that I run in memory of my mom, unrelated to the whole melanoma thing. And that turned into an opportunity for me to organize the Steps Against Melanoma event in the Boston area. We had our first event last year. It was successful. I'm hoping to grow that this year. And that event is coming up on Sunday, October 1st in Chelmsford, Massachusetts from 9 to 1. The reasons I volunteered, I think obviously I have my story, but I've seen the amazing breakthroughs between 2013 and my first diagnosis and today, and just the treatment options and the ability to diagnose and catch things earlier. And all of that money that gets raised at events like this help to fund that research. Also, with that genetic mutation, the really big part for me is if either or both of my kids have that mutation, I want to know that I did my part to help make things as great as it can be if they ever have to fight this battle. The other important part is raising awareness about melanoma, making sure people understand the ABCDEs, the importance of yearly skin checks, and how to minimize the risk. So for those reasons, that's why I'm involved here. Would love to see some of you attend this event next Sunday, October 1st. We're going to have a lot of great people there, music, games, raffle. So my favorite raffle this year so far is the Boston Celtics team signed basketball. We have a lot of local businesses contributing gifts for the raffle as well. We'll have free skin checks on site, so someone will give you a visual skin check. Ice cream truck, food truck. There's a playground if you have kids. My kids will be there. My family will be there. And working on a couple of other surprises here. So please consider joining us again, Sunday, October 1st, 9 to 1 at the Byam School. Thanks for taking the time to listen to me. Have a great weekend.
With that, I'm going to turn it back to Dr. Buchbinder and the questions.
Okay, so our first question is, does TIL therapy work on all types of melanoma?
So there's been some work looking at uveal melanoma and mucosal melanoma in TIL, but these trials have been small. I would say, I'm going to say yes, with like the biggest asterisks you could imagine, because we just don't totally know yet. We don't have bigger trials with other types of melanoma, but I think we do suspect that it likely will in those other types as well.
In stage 4 melanoma on standard of care with residual treatment, Are there any different or body specific approaches that have shown promise? And are there any way to decrease side effects in areas like that tend to have more side effects? For example, for like brain metastases, if they're on like stereotactic brain radiation, is there any way to reduce that edema? And are there any novel treatments for things like that?
Yeah, it's a lot in that one question, so I'll do my best to remember all the specific parts. I'll start with brain metastases first. Unfortunately, a number of our patients who develop metastatic melanoma will also develop brain metastases at some point. Amazingly, the combination of ipilimumab and nivolumab works better than we could have ever possibly imagined for that population of patients. It certainly doesn't work for everybody. But for example, if a new patient presents and has brain metastases, assuming they're not causing symptoms, we often can get away with treating with just ipilimumab, nivolumab alone, doing a short interval scan to make sure that the tumors aren't getting bigger, and then avoid the use of radiation in that setting. What we found out the hard way in many scenarios is that when you give immunotherapy, particularly with ipilimumab, when you give radiosurgery to the brain with ipilimumab, so high dose radiation, there can be a robust reaction to that that can cause symptoms and really impact the quality of life for patients even years down the road when their disease is otherwise under good control. So we certainly fold in radiation to symptomatic disease. If patient has a bone metastasis that's causing a lot of pain and we're starting therapy, we often do radiation to the bone metastasis at the same time. So, you know, we tend to think of melanoma as a disease that we need to treat the whole body for, but we certainly pay close attention to our patient symptoms and direct local therapies to particularly symptomatic treatments. I think another aspect of that question was, how do we think about toxicity and can we lower toxicity? Right now, there are no clear approved strategies to reduce the risk of toxicity in somebody who's going on treatment, other than we can select treatments that have a varying risk of high-grade toxicity. There are a lot of therapies or a lot of clinical trials right now looking at adding things to immunotherapy that hopefully won't reduce the good that immunotherapy does, but potentially reduce the bad that it can do in terms of minimizing side effects. We're not there yet in terms of being able to say for sure what's the right strategy, but we're thinking about this as a group and trying to sort out, hopefully in the not so distant future, approaches that can do just that.
Here's sort of two questions that I'll combine into one, but what is the difference between stage 0 and stage 1 melanoma? And are there any means of detecting it other than a physical observation or examination?
Yeah, so the difference between stage 0 and stage 1 is, so I don't, if you remember back to Dr. Cohen's picture where those melanocytes were kind of right on that epidermal border, it's when they cross over and invade into the dermis, they become stage 1. If they're still on that surface, so they're really abnormal, they're clearly melanoma cells, but they're still right along that surface, so what's called melanoma in situ, then it's considered stage 0. Now, there are tons of efforts out there to detect melanoma lesions earlier. And this is where we need a dermatologist to be here to talk about all of the things they're doing, because there are things where that involve microscopic, they can actually, and I'm not going to describe this well, I don't know if others could, they actually can look microscopically at the skin and see the cells. They have these machines that can do this to help detect if something is a melanoma. There are different apps that are being used that are actually looking at taking pictures of people's moles and can notice changes, although all of this, you know, so use of AI, use of these new techniques. So there's tons and tons of stuff going on in this space to detect melanoma earlier and earlier. So it's an area to definitely keep an eye out and but this is where our dermatology colleagues who we work so closely with are really the experts in terms of this sorts of stuff.
One question is tebentafusp effective with other rare melanomas besides the ones mentioned?
It's a good question. The answer is I don't know. Tebentafusp actually was developed at Oxford University in the UK. And their initial study that they looked at were patients with high-risk melanoma, not unlike the study that Dr. Ott and colleagues here did with their neoantigen vaccine, that initial trial. And it was difficult to sort of make heads or tails other than they could begin to describe some of the side effects that patients were having. And it seemed like they were reducing some risk of the skin cancers coming back. When they opened it up to a larger group of melanoma patients, and because tebentafusp is targeting an antigen GP100 that's really only expressed in melanoma and not other cancers, it was really only looking at melanoma patients, but it allowed other types of melanomas besides surgically resected stage 3 melanomas. And what they found was that the uveal melanoma patients treated had two interesting characteristics. One, they almost always had GP100 expression, which wasn't clear, but the case with skin melanoma. It was widely, there was sort of a wide array of expression of GP100 in skin melanoma, but it was pretty tightly clustered high expression of GP100 in uveal melanoma. So it seemed like if it's going to work at all, that was the population to study. And then patients seemed to be living longer than they would have predicted. And then that's what led to the subsequent trials. It hasn't been well studied in mucosal melanoma. And presumably the trial that'll be done, actually it is, the trial that's open and launched will allow for patients who have acral melanoma, but not mucosal melanoma.
Is there any potential to reduce the time of TIL therapies? The slide showed 22 days, sort of that elapsed time. And then is this like possible to even be shortened?
Yes, so that is a huge area that's being worked on, is trying to shorten that time. I mentioned that there's efforts to kind of modify these TILs, and of course, that's just going to potentially add time to that preparation. And and that 22 days, that's from the tissue arriving in the lab too. And there's all sorts of shipping and other things that get in there too. So no, there are huge efforts to kind of try and make that shorter, because you think about it, that's a patient who's now just waiting for therapy. The other thing that we're doing and trying to figure out with TIL therapy is whether we can use some sort of therapy as kind of what we think of as a bridge therapy, so that you get your TIL harvest, but then maybe get started on something in the meantime while those TILs are made, so that it's not like you're getting nothing for that time when it's waiting. But this is all areas that a lot of, there's a lot we've got to figure out as these therapies kind of enter into practice.
Just to follow up to the TIL therapy, a two-part question. During that period, that 22 days, are you able to get on another treatment during that time? And number two, are there any prior treatments that a patient might need to try before being a candidate for TIL therapy?
Right. So for the first question, yeah, so that would be that bridging therapy, and what that looks like, what that is, how that works. I mean, because the issue there is, if you get on a really good therapy and it works great, you might not need the TILs. So what does that look like? I think that's something we're still really figuring out. Now we don't know yet what so who decides kind of what therapies are required before a therapy is approved is actually that FDA. And so we don't know what that label is going to look like. So how we're assuming they're going to approve it, since all of the data is in patients who received prior immune therapies. We're assuming that that's where it's going to be approved, is in patients who've had prior immune therapies, but we don't 100% know. Sometimes if there are other stuff that's submitted, it may be that it doesn't require other prior therapies prior. On the trials right now, most of the trials are in patients who've previously received immune checkpoint inhibitor therapy, so Ipi-Nivo or others. And part of that reason is just because it is a bit intense. So the chemo tends to be given in the clinic, but the cells themselves and the IL-2 is given inpatient. So patients do need to be admitted to the hospital often for a couple of weeks if they're going to get the TIL therapy.
In a similar vein, is NGS testing required for TIL consideration?
So no, we do like to do it. And the reason we like to do it is because it's how we get so NGS testing is next generation sequencing. And so what we do is that's how we know that a melanoma has a BRAF mutation, NRAS mutation, all of these other mutations. For TIL therapy, we don't need to know that. For vaccine therapies and other things, we do need to know what those mutations are. And so often that sequencing is part of the whole process. But for TIL therapy, because those immune cells are taken out, we don't necessarily need that information, but it is something we usually do pretty early on in melanoma treatment.
This question is in relation to stage 4 melanoma that has moved to either the brain or the bone. In cases where radiation did not produce a positive effect, either from a tumor reducing standpoint or from a quality of life or side effect standpoint, what are some things that can be tried?
Yeah, that's a tough scenario. We commonly will take patients to the operating room for brain metastases that are causing problems and aren't responding to treatment, whether that treatment's ipi-nivo or targeted therapy or radiation. We also will take patients, even if they're initially presenting with a brain metastasis that's symptomatic, we often will try and remove that if it's safe to do. Bone metastases are difficult. If fortunately most actually respond, not necessarily go away, but are made symptomatically better with radiation therapy. However, in the setting where radiation therapy isn't helpful, or has helped and then is for a short period of time, and then it kind of it doesn't help for long enough. Sometimes we can do surgery, particularly bone metastases in the spine often can be removed, and then there can be stabilization procedures done. But it's a really challenging problem. We do the best we can with systemic therapies. We do the best we can with other ablative techniques like cryoablation or things like that. But it's a big problem that if our standard approaches for one tumor isn't working and you can't take it out, it can be very tricky to manage, the tumor itself.
Can melanoma on the skin spread to the eyes? If you had a cutaneous melanoma, are you more likely to get a uveal, mucosal, or other type of melanoma?
There's a couple things in that. So first of all, unfortunately, metastatic melanoma can sort of arise anywhere in the body, and we have definitely seen metastases in the eye. There's also an overlap and the overlap can be two things. There are clearly some inherited genetic syndromes that patients are more susceptible to develop both eye melanoma and skin melanoma. And so anybody who is diagnosed with eye melanoma, because it's rarer, we recommend they see a dermatologist to be screened and followed for the development of skin melanoma. I lost my train of thought. I'm seeing something that says soup to nuts, and I only can think of is soup and nuts right now. Answer the rest of the question. I think I got it. Yeah. No, I don't. I've lost again. I don't know the rest of the answer to the question. I think the bottom line is, I do know it. I don't. Gosh darn it all. Okay, so I think I answered the question. Yeah. Somebody needs a better answer than that. They need a better oncologist to answer it than me, which is not hard to find. There's an oncologist right there.
And so our final question is, what is the best way to know if you are getting the correct post-cancer treatment?
Yeah, that is so, the concept of survivorship, which I think this question is asking, is a complicated one. An argument could be made that anybody diagnosed with cancer is immediately entered into survivorship. They're living with cancer And there are issues that need to be addressed beyond, I have cancer, I need treatment for cancer. We at Mass General and certainly other places are beginning to think about, okay, what are the unique aspects of survivorship in patients who have received BRAF targeted therapy or who have received immunotherapy? We're trying to learn from our colleagues that have been thinking about this for a long time. In the field of oncology, it really was childhood cancers, where a lot of the survivorship issues were identified because kids got a lot of toxic therapy and then had legacy issues related to that. And then in non-hematologic and adult cancers, it's really the breast cancer field where survivorship has been pioneered. There are clear issues that we see. So anybody who's been on therapy with us after, and then they stop, whether they were on adjuvant therapy and stop after a year, or they were on for metastatic treatment and they had an amazing response and we stop after a year or two, we try and have them see one of our nurse practitioners who's trying to build a survivorship program to talk about, okay, here are the 50 things we need to think about now that, we were not ignoring, but not actively thinking about. Are you on any medications that we started because we blew out your thyroid or your pituitary gland or whatever else? Even though we caused it, we want your primary care doctor to prescribe those medicines. Like, that's a simple punt. It seems weak of us to do that, but like, that's an example. But also, are you having issues with your libido? Are you having issues with dealing with sort of reentry into life off of treatment? Are you having financial issues because you had to pay for your treatment or you had to come back? There are a lot of things that we just don't ask, not because we don't care, but our time is limited and we're actively managing the cancer and thinking that those are important questions, but gosh, we really need to get this dealt with first. And so I think as we get smarter, as we have more and more patients going into this transition from active treatment to then follow-up, we're trying to address these in ways that are more systematic than the word that's the opposite of systematic.
So I want to reiterate that we're doing very similar efforts here at the FAR. We're trying to build that program because there are so many things that tend to fall by the wayside when people are actively getting treated for cancer that really are very important. And in addition, that we don't know entirely some of the long-term effects of these immunotherapies. And so we want to make sure we're watching for later toxicities or long-term effects. So so that a lot of active work going on all over town in this space, looking at survivorship. So that's actually like a fantastic end note of being able to end on that. So I want to thank our entire panel as well as everyone who came today. Thank you for taking time out of your Saturday to talk about what we can talk about all the time, which is treatment of melanoma. So we really appreciate you coming, and if there are other questions, definitely submit them to AIM to be answered. So thank you all. Thank you.